Dr. Made Wiryana for joining us today. And before we begin, I would like to invite Professor Made Wiryana to give a welcoming speech to start this guest lecture today.
So I want to introduce that for all in this room, my staff, uh, and a few of them of medical student, and a few of them of our anesthesiologist registrar. As you know that we have a lot of anesthesia registrar, about 150 registrar, but a few of them just here and maybe still in the teacher or in the intensive care unit. So once again, welcome you. Thanks once again in this afternoon. You give a lecture. We hope that all of that can improving our services, especially in anesthesia pediatric, because you know that we have a lot of pediatric patients in this hospital. This hospital is a referral hospital, so that's why we receive more patient, a lot of patient from the outside of Denpasar. This is one of central hospital in Bali and of course in East Indonesia. That's why we have a lot of patients, especially for pediatric patients. So that's why once again, thank you very much for your coming with us here, and we hope that all of the audience must appreciate this afternoon because the expert from abroad with us for today, and we hope that all of you enjoy this meeting. Maybe a few of them by Zoom. That's right. Oh yeah, that's right. So for the audience outside of this hospital that with us with Zooming, once again, thank you very much. You are attending from us here and to heard about the lecture of our friends from abroad, Professor Luke. Thank you very much for all of you. Once again, good afternoon, and once again also welcome, Prof. Luke. Okay, thank you.
Thank you so much, Professor Made Wiryana, for a warm and thoughtful welcoming speech. Okay, our session will be moderated by Dr. Putu Herdita Sudiantara. He is our anesthesiologist in Professor Murah Hospital. And also, we have Dr. Samuel Dwi Putra Wijarnarko, an anesthesia resident, joining us as our case presenter today. Okay, our first session is case discussion about congenital diaphragmatic hernia that will be presented by Dr. Samuel and Dr. Heriana as a panelist and Dr. Herdita as a moderator. Okay, last but not least, I would like to take a moment to go over a few housekeeping details. The first one is mobile devices. Please keep in mind to keep your mobile device to silent mode to avoid the interruption during the lecture. And the second one, we have a Q&A session following the lecture. So please keep your question until that time, and during the Q&A session, please raise your hand and I will give the microphone to you. And for our online participant, please leave your question in the comment section and our committee will try to answer the question. Okay, without further ado, it is my great pleasure to welcome Dr. Herdita as our
Thank you,
moderator.
Chitra. Okay, good afternoon, everyone. My name is Herdita. I'm honored to be the moderator of our event this afternoon. Before we begin, we also like to extend your warm welcome once again to our panelists and the guest lecturer today, Dr. Heriana and Dr. Luke Tillens. who will share another interesting knowledge for us about congenital hernia diaphragmatica and the caudal or ilioinguinal in children for hernia repair. Okay, I want to encourage you all, of you or our audience, to actively participate in today dialogues. Your questions, your comments, and contribution are essential in our shaping to understanding and expanding our perspective of this topic. Without further ado, I will invite our guest presentation for today's lecture, Dr. Samuel, and our panelist, Dr. Kade Agus Heriana, to take the stage and kickstart our guest presentation today. Okay.
So, good afternoon, Om Swastiastu, to my fellow friends, our professor and our teacher. Let me introduce myself. My name is Samuel Dwi Putra Wijanarko. I'm an anesthesiologist residency from Medicine Faculty of Universitas Udayana. So I would like to present one of most common pediatric surgery. It's about congenital diaphragmatic hernia. I would like to remind everyone what we should do if we got this patient and how we manage in our surgery room. So there's one patient admitted to the hospital, complaint of shortness of breath since 10 minutes after his birth. So the patient was referred directly to the neonatus intensive care unit at the RSUP Prof. Ngurah from Puri Bunda Denpasar Hospital with respiratory distress syndrome and with diaphragmatic hernia. So the baby was born with C-section on 21st of October 2024 at 4:31 p.m. and then immediately cried with clear amniotic fluid from when she was born. And then 10 minutes later, she was said to be experiencing respiratory distress and getting worse. So the patient taken a babygram photo, and then the result, she had a diaphragmatic hernia was obtained, and then the patient referred to the Prof. Ngurah Hospital. There is no history of vomiting, but there is meconium urination when she was born, and there is no bloating, no distended up from her stomach. There was no history of congenital heart disease and other illness. There was no history of drug allergies before. There was no history of previous surgery. So for the pregnancy history from her mother, the baby was born with maternal diagnosis, the first child from gestation 37 to 38 weeks with decreased weight intrauterine, or we call it IUGR, and the non-stress test pathology. So the indication for the C-section is for the nasty pathology with the IUGR. For the mother, history routine antenatal care at the midwife and obstetrician. The patient was born with Apgar 7 and 6. So born with C-section, immediately crying with birth weight 2,900 grams and birth length with 48 centimeters. So from the physical examination, we got from the weight to the same 2.9 kilograms and the length 48 centimeters with the temperature 36.7 with head diameter 35 centimeters and the leg diameter 32 centimeters. So the patient for the cardiovascular profile, the blood pressure 70 per 32 millimeter, heart rate 160 to 170 times per minute. So the cardiac sound, there is regular, no murmur, no gallop. So we can hear the sound of the cardiac from the right of hemithorax. From the respiration, the respiratory rate 63 times per minute, symmetrical chest movement, the vesicular breath sound, the right lung is more visible than the left lung, no wheezing, no rails, but the peripheral oxygen saturation about 91 until 99% on ventilator. So we got this patient, they is already gotten ventilator with volume control, assist control with oxygen fraction 35%, respiratory rate 40, PIP 6 with peristaltic sound at left hemithorax. From the abdomen, there is no distended, peristaltic still we can hear it about 4 times per minute. There is no difference muscular, no distended. There is normal from the urogenital, from the musculoskeletal. The extremity is warm with capillary level time below 2 seconds. There is no edema. For the malamity, we cannot evaluate it. There is no vertebral defects, no atresia ani, no cardiac defects, no tracheoesophageal defects, no renal abnormality, and lymph abnormality. So from the laboratory findings and the radiology findings, we got the blood sample. From the blood samples, the white blood count is a little bit high, it's about 16,440. And then for the hemoglobin is 16, hematocrit 49.2, and then the platelet 318,000. For the coagulation profile, renal function, electrolytes, it's normal, but there is a little bit elevated liver function around here. So when the babygram performed, so the result, left diaphragmatic hernia that pushes the trachea, heart, and mediastinal structures to the right side. Currently, there are no visible signs of ileus or pneumoperitoneum. The endotracheal tube is seen with the distal tip projecting at the level of thoracal 4 paravertebra on the right side, and the gastric tube was installed with the distal tip projecting at the level of the lumbar 3 paravertebral on the left side of the lateral aspect. So we examine it, and we conclude the problems at the conclusion. So the actual problem will be there is from the central nervous system, the patient is neonate. And then for the respiratory system, we got the respiratory disease at causa the congenital diaphragmatic hernia. And from the abdomen, we got the congenital diaphragmatic hernia that goes to the thoracic cavity. And then from the potential problem that may happen during the surgery, that can lead to bronchospasm, laryngospasm, desaturation, hypoglycemia, bradycardia, hypothermia, and vagal reflex. For the surgery condition, will be at abdomen and position supine, duration about 1 until 2 hours. There is no manipulation, and for the constitution, patient is ASA3. So our preoperative preparation that we can do is we need to still to inform the parents about how we gonna do the anesthetic. So the fasting about 6 to 8 hours preoperative, statics pediatry, anesthetic and emergency drugs. We need the sulfasaltropine, IV line warmer, and mattress warmer, capnograph, and endotracheal tube. We prepared if we need to change the tube during the surgery. The blood products, stethoscope precordial, and then neonatal intensive care unit with the ventilator. So our anesthetic planning using the general anesthesia with oral tracheal tube. So we will giving the premedication using the sulfasaltropine 0.1 milligrams IV, and then analgesics fentanyl 5 micrograms IV, and we do the induction. We given the oxygen and the sevoflurane 6 to 8%. Then we confirm the placing for the ETT, symmetrical and bilateral auscultation, and then we give some packing to make sure that there is no leakage. So during the maintenance, we given the oxygen, compressed air, and with sevoflurane, and we can give the under medication with paracetamol 40 milligram IV for multimodal analgesia for the postoperative. So for the postoperative management, we give continuous fentanyl about 100 micrograms in 10 milli of normal saline on 0.6 milli per hours, and then paracetamol 40 milligrams IV every 6 hours. And then after surgery, the patient going to the neonatal intensive care unit with ventilator. So this is the clinical picture before the patient got operated. As we can see, the patient is already got with the endotracheal tube. And as we can see right here, the oxygen saturation is only 95. And then this is the ventilator that when happening in the neonatal intensive care unit. So this is the photo before the surgery. As we can see in the thoracic cavity, we can see there is the intestine and the colon on the thoracic cavity that from the through the diaphragm. So this is what we found and in the surgery. As we can see right here, there is a hole right here. This is the Caudal hernia in the diaphragma. This is and the posterior margin of the diaphragma. This is the defect that leads to the congenital hernia in this patient. And then after the surgery was performed and the intestine we giving it out to the back to the up to the stomach, and then we just close it with stitches from the pediatric surgery. So this is the hemodynamics during the surgery. This is when the surgery start, and this one this is after the surgical procedure is done. So this is the patient with the incisional or when the pediatric surgery does the operation. And this is before we go transport the patient to the neonatal intensive care unit hemodynamics profile with heart rate 127 and the oxygen saturation is 97% with fraction 35%. So this is when the patient got to the neonatal intensive care unit. As we can see, the saturation is getting better. It's 100% with 40% of oxygen fraction. And we can see for the blood pressure is 82 per 47 without any support. So this is when we give follow up for the babygram photos. As we can see too, the thoracic cavity is already normal and the cardiac is already in the middle of the thoracic cavity, and we cannot, we didn't see any more about the intestine or the colon in the thoracic cavity. So we go to the discussion about the congenital hernia diaphragmatic.
Thank you, Dr. Samuel, for the excellent case and interesting case presentation. Now we will open about maybe 15 minutes of discussion of this case. Is there any question for the participant?
Before we go to discussion, feel
Dr.
free
Arya.
to raise your hand if any discussion. Our patient is full-term baby with born with the low Apgar scores, and she is weak cry, and we saw it is respiratory distress, and then appears dyspnea and cyanotic. Maybe from the clinical presentation, there is generally barrel chest and scapular abdomen, and maybe later in the X-ray we saw that there is a air-filled loop bowel in the chest, and the diaphragm, the mediastinum is shift or forced to the contralateral side. And maybe 4 of these clinical signs is suspected for the CDH. So our objective here is to discussion is one is to identify what is the pathophysiologic changes in this patient, and then to evaluate the role of anesthesia in the perioperative periods, and communicate with multidisciplinary team to get better outcome of this patient and patient safety. Okay, if you had any question, please feel free to raise your hand.
Associate Doctor.
Joseph.
My name is Feon from resident of semester 4. I want to ask the about this is one kind of excellent case from congenital diaphragmatic hernia. How can the congenital diaphragmatic hernia affect the respiration of the newborn baby, and how can we manage the respiration of the newborn baby?
Okay, thank you. Good question. Maybe the point is we must know the pathophysiological changes first. CDS is birth defects. It means that diaphragm is not intact. There is a hole in diaphragm during the gestation. Okay, it's during the gestation, and then there is a force from the abdominal organ can go into herniation to the thoracic cavity during the gestation. This situation is look distress. And then if we how to manage the ventilation if the patient is upon this is a emergency situation, then what we call a resuscitation is neonatus. This is maybe special case for the resuscitation phase. If the patient is spontaneous ventilate, we must give the ventilate the patient in a proper way, because if we give the patient high volume and high pressure, there is a possibility of the barotraumatic of the lung, and then it can lead to pneumothorax on the both side. And then we must use the ventilatory device like neopuff or ambu-bag that has a pressure limiting valve that not above maybe 14 or 20 millimeter Hg, and then the ventilate gentle, or if the patient for spontaneous breathing, we can achieve the maybe like clinically saturation, like preductal saturation is like 19.2 or 19 is also okay. And then if this patient there is deterioration 10 minutes after the labor, the pediatrician doing the intubate to optimize the condition that may be suspected at hernia diaphragmatica. And you go for later the ventilatory measurement, maybe setting pressure like 14 or until 20, and then we must put like tube, nasogastric tube, to decrease to decrease amount of or pressure air in the stomach, which can be the worsening the volume of thoracic cavity. Yes, patient and then must be nil per os. Later one, maybe the setting of PIP, we can give 3 or 5 PIPs, and then the target is like preductal still 80 or something like 19%. Maybe like that.
Hello everybody. Selamat sore. Siang. Sore. Thank you for your kind introduction of the speakers and the professor. My name is Luc Tielens. I'm from the Netherlands. This CTH is something that is in the Netherlands mostly seen prenatal. So we are not really all of a sudden confronted with it. So we have more time in advance to prepare to get this baby born and then see how it will react. So that's a bit different already. I would like to comment first a few things that were on the slides, if that's possible. It starts with the slide that, can you go backwards to the front? Somewhere to the front? Somewhere? Stop, yep. Can I walk up there? Yeah? Okay. Can you go one more back? One more back? Just a few common things. There was something about the malampati.
Oh, malampati.
You know malampati?
Physical examination.
One more back. Yeah. Malampati can't be evaluated. I think that everybody that deals with pediatric anesthesia knows that the airway, the anatomical airway in small children is completely different compared to adults. And these small kids do have a very big tongue to make it possible to ventilate, to suck the milk with less vacuum space. Can you still hear me? Because that's much easier because I got this one. I have two now. But since babies need a very big tongue to make a good vacuum in the mouth, to suck milk from the breast or the bottle, and the whole anatomy is built to drink and breathe together. We can't do that anymore. If we do that, we will get some drops in the wrong hole and we can't stop that anymore. But the anatomy in the baby is this partly changed that they can breathe and ventilate, drink together. But they need that because they have to aspirate, to make a vacuum very strong to aspirate the milk. Meaning this big tongue has to be there to make that space in the mouth as small as possible so they don't have to suck too much milliliters of air to make a good vacuum. Meaning if you have this big tongue, what does that mean from your malampati? Every baby has a malampati 4, always. Just born babies have a malampati 4, right? You don't need to think, we can't evaluate. If the baby is 1 year old, it will be a little bit better. How can you evaluate that? By giving him this toddler. He has a toddler in, you take it out, he wants to take it back, you can watch it. You can look in the mouth. The moment you want to put the toddler, you know, the bottle or the toddler, back in, he will open his mouth and you can have a look inside. But this small, you don't have to do it. One more. Another thing that I saw. Can you go to one slice more? One slice more. You use adrenaline, is that here? No, one slice more. You use adrenaline SA 0.1 milligrams IV. Is that correct here? Because we use 10 micrograms per kilogram, but this baby is let's say 2.9, let's say 3 kilograms. So it means for us, we should have used 0.03. That's 1/3. But maybe you use more. I'm not sure about that. How much adrenaline you use in the babies. You see what I mean? We should use a little bit less. And we have changed a little bit in this pre-medication. We are not giving it anymore as a pre-medication because we are used to give less and less deep anesthesia from the start. So we don't use it anymore regularly, but only if the baby really gets a bradycardia. And then you have it rescued as rescue medication very close by. If you see the frequency is getting towards a bradycardia, we take the adrenaline and we inject. So not from the start anymore. And what I miss here is actually, do you use relaxants? No relaxants used, right? Now we use relaxants in these babies. Yeah. It's the differences, but it's like, yeah, we want to have them really relaxed to make sure that your ventilator breathing is all he gets and not interrupted with the pressure from itself. So that's why we use it. Just as a case, one more slides more. What did I saw more? Can you give me the other slide? No, I think more than that. Here, this one. As the doctor already explained, we know from advanced that this baby will have intestinal and maybe the stomach inside of his thoracic area. So from the start, we will put a nasal gastric tube before we put the mask and start to ventilate, because every breath you will give will be with a little bit positive pressure and can go into the gastric area. And if it pumps up your gastric area, there is even less space for the lungs. It depends in these babies more and more about what, how did this lung develop during the pregnancy? How much could this lung develop while there was some intestinals and maybe gastric and other things inside that thoracic area? How much did that compress and block the growing of this lung? And it's very important to understand that this is actually the limit of the disease. Then the baby is going to be born. Just before born, we all know that the hormones in the mother changed the way of acting of the lung cells in the baby. During pregnancy, the lung cells are producing fluid, filling up the lung with fluid, meaning there is a very high resistance for the circulation. The body has something to not put all the right heart cardiac output through the lungs, but they have a ductus botalli to push it into the normal the bigger circulation. So not all the blood coming from the right heart goes through the lung, but most go just in the central circulation by the ductus botalli. And the right atrium is not keeping all the blood to the right heart, but it's also going into the left atrium and going into the bigger circulation. So we're actually bypassing the lungs, who have a very high resistance due to the fact that it's completely full of amniotic fluid, mostly made by these lung cells itself. Just for born, there is a hormone produced in the mother that changes these lung cells to not producing the fluid, but taking it up. Then the baby is born. A lot of this amniotic fluid will be pushed out by giving birth. The head comes through the birth channel, and then the birth channel is pushing on top of the chest of that baby, pushing out about 1/3 of the amniotic fluid. And then what happens? The baby is in the free air. What happens in the free air? It's cold. What happens if I put a cold shower and I'm standing under the cold shower? What is my first reaction? I'm here just breathing normal, and then in the cold. That's the baby doing also. And in this reaction,
He's aerating his own lungs. And then he starts to cry or breathe more and more, he will aerate his whole lungs. If these lungs are normal and they are totally aerated, the resistance is very low. Because the fluid is gone and the system of the vessels in the lungs will be very low. Meaning from a very high resistance to push blood through the lungs, it becomes very low. And so what is producing in the right heart is pumped into the same system, but doesn't go into the central system anymore because there is a higher resistance, but goes through the lungs. But what now if half of the lung is still very resistant because the lung is not really developed well and is actually a conglomerate of, and having a tight, more structure instead of an open structure? There will be a resistance again. So the most important thing is, after birth, see what's actually happening with the pulmonary vascular system. And there will be mostly a pulmonary hypertension. And that's a problem for the right side of the heart. And this is something that is really important to monitor. And this is something that is also nowadays in my country the reason to see what moment will we operate this kid, right? That we will send these kids mostly intubated, gastric nasal tube, ventilation, make them sleep, put the intubation as low as possible pressure, and then to the ICU, to the NICU, neonatal ICU, and see how they stabilize. Some, they don't stabilize and get very twisting up and down, having a pulmonary hypertension, and you can't really get them good stable, so they need really intervention from the intensive care unit, intervention from the neonatologists to try to get that baby stable. Some become stable within a few hours, and it seems that this baby became quite stable because it came with quite normal values of respiration and circulation. And then you should understand what will be the moment of surgery. I don't know if this presentation goes on in that direction or we can just discuss it. Yeah, first a little bit more like the discussion. Okay?
Okay.
Some questions about that?
I will try to translate.
So,
Okay.
yeah. Oh, okay.
Maybe karena penjelasan cukup bagus, jadi saya akan coba membantu teman-teman di sini untuk kita. Jadi dari Dr. Luke Dillon sudah mengatakan bahwa pada kasus hernia diaphragmatika itu ada 3 hal yang perlu kita perhatikan saat preoperatif, anestesia manajemen, dan juga postoperatif care-nya. Di preoperatif tadi sudah dibahas oleh Dr. Luke about the malampati. Ya, malampati itu kita tidak bisa periksa pada pediatrik karena memang susunan anatominya sudah berbeda dengan tujuan yang berbeda. Kenapa diciptakan lidah itu besar? Supaya dia menghasilkan ruangan yang cukup kecil di dalam rongga bibir, sehingga ketika dia melakukan nyusu atau dia laktasi, dia menghasilkan tekanan yang cukup besar. Jadi itu fungsinya kenapa lidah besar pada pediatrik itu gitu. Dan anatominya juga dibuat seperti demikian karena memungkinkan bayi itu menyusui sambil dia bernafas gitu. Kalau kayak kita yang besar gini kan tidak bisa gitu. Jadi kita makanya sering tersedak gitu. Jadi memang tidak tepat kalau kita melakukan evaluasi malampati karena berbeda untuk anak kecil. Makanya kita sering buat dia tidak dapat kita evaluasi, artinya seperti demikian ya. Setelah itu dari beliau juga untuk premedikasi penggunaan sulfasatropin. Menurut beliau tidak rutin dilakukan oleh beliau saat ini, hanya digunakan untuk melakukan tindakan-tindakan emergensi saja atau ketika terjadi contohnya kasus bradikardia. Setelah itu juga beliau juga rutin menggunakan pelumpu otot pada kasus-kasus neonatus seperti ini. Nah, yang ketiga untuk postoperatif gitu, kenapa harus dilakukan perawatan di ruang intensif ya? Jadi karena dalam teori pun terdapat honeymoon period di mana ketika dokter bedah melakukan suatu hal yang baik sekali gitu, tetap ada permasalahan secara fisiologi dan anatomi pada paru pasien yang mengalami hernia diaphragmatika. Biasanya kita sering sebut dengan pulmonal dysplasia atau tidak terbentuknya vaskular dan juga alveoli di sana karena terpres oleh usus yang waktu di dalam kandungan. Nah, Normalnya ketika dia di dalam janin itu tidak ada aliran ke paru-paru, jadi dia membypass aliran paru tersebut, ya dari pulmonal tidak ada lagi, sehingga ketika bayi itu keluar dia menangis, terjadi pengembangan paru terbuka, resistensi menurun di sana, ada flu yang masuk, itu harusnya menurun. Tetapi pada pasien-pasien dengan CDH ini dia seringkali tidak terbentuk vaskularnya atau tetap tinggi. Jadi hal yang perlu diperhatikan menurut Dr. Luke adalah tekanan pada jantung kanannya, karena jantung kanan dari ventrikel kanan itu akan memberikan darah suplai ke paru-paru, sehingga ke paru-paru. Jadi kita harus melihat, memperhatikan bahwa apakah ada pulmonary hypertensi apa tidak, ya, karena itu akan berpengaruh pada jantung kanan pasien. Nah, setelah dia operasi pun gitu, tidak langsung terbentuk atau terjadi perubahan pada pulmonary hipertensinya ini gitu, makanya dia perlu dilakukan perawatan di ruang intensif gitu ya. Jadi mungkin itu gambaran yang diberikan oleh Dr. Luke. Sekarang beliau memberikan kesempatan lagi untuk teman-teman setelah saya jelaskan tadi, apakah ada yang ingin ditanyakan lagi. Okay, there is any question maybe in our YouTube channel or in this room. There is another question.
Okay, thank you for the time. I'm
Okay,
Jayanta for the Registrar of Anesthesia. I want to ask, how about the minutes of ventilation?
Maaf ya. sorry.
Okay,
Pertanyaannya untuk siapa?
for the Dr. Heriana.
Oh, for the
I want to ask about how to manage the ventilation for this patient during the operation, and how the target for this patient. Thank you.
Thank you for good question. Maybe just like Dr. Luke said before, we must continuously clinically or during the NICU period, patient is we pulmonary hypertension, and if the difference is bigger and getting worse, and we saw juga there is a failure in the respiratory, we see that there is a decrease saturation, and then we put a pressure, low pressure, and the PIP, low PIP, and we with the target of maybe like pulmonary artery oxygen like 19 and PaCO2 like 45 or 50. If the lung is very stiff, we can also give the permissive hypercarbia, like maybe 16 or 7, more than 17. We put the saturation first because if the hypoxia, if the baby hypoxia, it get worsen the pH, and then we manage the thermia. If the baby hypothermia, it get worsen also, and then if the baby get pain, it getting worse also. Yes. And then we setting the ventilator and the target hemodynamic and ventilation is also good. Just like in the ICU, NICU, if the baby worsening, like the target is not achieved, we can change the modif the ventilator. If more acidotic, we can use the high frequency ventilation to decrease the volume. And if there is worsening also, maybe ECMO, but we don't have here if available. Another way to decrease the pH is using sulfuran and propofol, maybe lowering the vascular tone, maybe like nitric oxide if available, but there's no available here. Kemudian, and then we can give maybe something like milrinone. We load and the dose and give the extra titration. Another one is we give sildenafil IV continuously. Okay. Maybe Dr. Luke, I don't know here there is no measurement exactly what the pH is.
No, I don't. Still working? You hear me? Yeah. No, I think it's a bit. Yeah, cannot really say like. Yeah, you need to see how the baby reacts when you put some more or less, and it's very important to understand that if these intestinals are taken out, the limit is by how is that lung on the left side developed. And as you could see later in these slides, in this presentation, you see after the operation, the left lung is quite good developed and is filling up the whole thoracic area. So you are not that afraid of having a lot of problems with it as a normal ventilation. You can start normal ventilation. The moment the surgeon is taking these intestinals down, trying to get it out of the thoracic area, he can directly see if the lung is getting more and more open and aerated. It's like a recruitment of that lung. But if it's not really developed, he doesn't see anything appearing. He sees lung tissue, but it's not getting aerated. So then you know, if you close up the thoracic area, that this parts of the lung might be functioning, but parts not. And you will not have this nice clear picture as this baby showed us. Right? You need to translate?
Oh ya, jadi yang dijelaskan sama Dr. Luke adalah tidak ada satupun penanganan untuk PH kita, strategi kita manajemen ventilasi. Jadi kita sebisa mungkin harus melihat reaksi dari babynya itu. Jadi apapun yang kita berikan gitu, kita tetap kembali ke klinisnya. Jadi istilah kita tailor made gitu loh. Jadi kita tidak ada satupun yang memastikan bahwa strategi yang terbaik untuk melakukan ventilasi itu seperti apa. Jadi kita tetap melihat respon dari si pasien tersebut atau si bayi tersebut ya. Oke. There is one question from outside of here. There is Dr. Iren. She has it's prone to suggest early chest tube placement after the surgery because of pulmonal dysphagia, or because after the operation patient will be controlled by the positive pressure and then the risk of the pneumothorax. So it's possible to suggest the surgeon to do the VSD water seal drainage first after the surgery, or
it's not suggested in my hospital. You want to have this lung developing itself and exploring itself, and it's getting aerated more and more. And if you put a chest tube in advance, you may try to get a little bit of positive pressure from outside to open up the lungs. But if the lung can't open, then it's a negative pressure on the outside of the lungs. And that's also something you might not want. the chest tube itself can harm the lung and make a hole there, so you have a pleural fistula, then you need the chest tube. But from the start, we don't put it in. We just let the lung itself open and see how much there is functional lung finally.
Okay.
So it's not from the start a chest tube.
Okay.
Do you do here chest tube from the start?
No,
No.
no also. Well, maybe I ask if the baby from the pregnancy, the obstetrician found the CDH what would do in Holland.
The?
What the team do in Holland?
The
If-
team
Yeah,
for this
during pregnancy.
during pregnancy. I have my microphone now. What we nowadays do, I had the luck to be living in a very high developed country, and what we do nowadays is we see this problem already in advance. What they do now intrauterine is actually placing a balloon in the trachea, obstructing the trachea, meaning the fluid that is made in the lung stays in the lung and doesn't come out and mix with the amniotic fluid. Meaning this fluid in the lung is a contra pressure against the intestinals trying to get into the thoracic area. These growing organs are looking for a space to stay comfortable. And if there is a hole into the thoracic area, yes, the gastric parts of the stomach can go in, or intestinals can go in. But if the lung stays full of fluid and is producing itself more and more fluid, it has a contra pressure against the intestinals to come into the thoracic area, to come through that hole higher up. Meaning, with that, they tried to have a therapy for having the lung not developing. But you should realize these women should stay close to the hospital, because the moment the baby is born, this balloon has to go out because the baby needs to breathe and needs to have an open airway. So just before born, they go in again, they pinch the balloon, it deflates, you take out that catheter, and the baby can be born and have an open airway. That was your question, no?
Thank you. If the pediatrician surgeon do like the laparoscopic or thoracoscopic in Holland?
We do that if this is a smaller smaller hole and a smaller amount of intestinals into the thoracic area. If we actually can see already here, you see it high up into the left thoracic area, so this might not be something that they can easily do laparoscopically. The problem is, get this all intestinals that are in the thoracic area grown, might not be easily come back in the same hole that it came into. So that's the problem. And then if you have a laparoscopic start, then they might not manage to get it out. They still have to open up. So they do sometimes do it laparoscopically from below, and then they try to do it. But only if it's like this, they will start directly open, because this is very much in the intrathoracically. You understand what I mean?
And then if we
Right.
do,
Hmm?
That's the last question.
Yeah, okay. No, it's okay.
Well, I think if in Holland there is operation losing double lumen tube, or
A double lumen tube? There is no, the smallest double lumen tube in my country is about 35. That means it's about a tube 6.5 to almost 7. So you can only use that in patients about 14 years old or something like that. So these babies, if you want to do single lung ventilation, you can, but you should do another technique. You should block one of the bronchial trees, if you want to have single lung ventilation, by a Fogarty catheter. That is possible. And in these small ones, you should use a 3 French Fogarty catheter. That's a special technique. I explained this a week ago in the Anesthesia Congress, but it is something like that. In these babies, you don't have to do that. In the very small babies, it's very easy to push the lung aside. This lung is not used because it's not explored. It's not open, since after born there is intestinals pushing it back. So the surgeon can easily keep this back. You understand what I mean? So there is no reason to do this in a single lung ventilation situation.
How to put the four-gate catheter on the right side or left side? Using what?
What we do is actually, if we do kind of a surgical operations in small kids and they need a single lung ventilation, we first put a laryngeal mask in. We do the anesthesia, mask, IV, laryngeal mask, and then we do everything: arterial line, epidural, urine catheter, maybe an extra IV, maybe a central line, everything, and then we do the airway management. And the airway management starts with laryngeal mask out, Fogarty catheter in. You can bend the Fogarty catheter with a little corner, and if you push the corner to the right side, if you go through the glottis and you have the corner to the right side, mostly without any problem, you will push it in the right side. If you turn it around 180 degrees, it sticks to the left side. If it goes in the left side, you say hooray. After the Fogarty catheter, you put your normal tube. That was something that was inside. We always use cuff tubes. So we blow the cuff, and then the Fogarty catheter is a little bit stuck. You go with your bronchoscope through the tube, and you look, where is my Fogarty catheter? If it's in the right side and it needs to be in the right side, you only have to withdraw it till you just see the balloon. If you just see the balloon, you blow the balloon, you see it bulbing up, and you know that your right bronchus has been blocked. If it needs to go left, but it is right, you can deflate the cuff of the tube, and you can manipulate to try to get it in the left side. I have quite a handy thing, so mostly I can get it in the left side. But if you can't get it in the left side, then you withdraw everything, you take one size smaller tube, you put that tube in, you put your bronchoscopy, and you go with the bronchoscopy in the left lung, in the left bronchus. You put your tube in the left bronchus. You take your scope out, you put your Fogarty catheter in, and you definitely know it's in the left side. Then you take this tube back, and it's on the Fogarty catheter, but you can't get it out there. Leave it. Take a next tube, put it in, blow the cuff, and look with your scope. Hey, my Fogarty catheter is left. But here, somewhere outside the baby, there is a tube around the Fogarty catheter. But that's not a problem. That tube was to guide it into the left side, and the new tube is to breathe the right proper lung. Understand what I mean? That's how we do it. Okay?
Udah. Oke, mungkin ya Dr. Lu tadi sudah menjelaskan bagaimana ini penting sekali tekniknya, gimana cara kita membuat single lung ventilation pada pasien-pasien neonatus, di mana kita kan sulit. Jadi kita bisa menggunakan teknik block. Jadi kita block pakai masuk itu dengan cuff-nya supaya tetap posisinya. Jadi tidak masuk lewat dalam lumen tube-nya gitu. Tapi kalau memang nggak dapat kita di kiri yang susah, jadi beliau menyarankan menggunakan tube yang lebih kecil. Intubasi biasa dulu pakai tube yang kecil, lalu dimasukkan bronkoskop. Nah, kita kan masalah kita tidak punya bronkoskop yang lebih kecil. Kalau ada yang lebih kecil ukuran bronkoskopnya, kita bisa arahkan ke kiri, lalu kita dorong lebih dalam lagi tube-nya dan memastikan tube kita ada single lung di kiri. Nah, setelah itu baru masukin Fogarty-nya, kembangkan balon Fogarty. Nah, tube ini kan tidak bisa keluar kemana-mana, ditarik taruh di ujung Fogarty-nya, baru menggunakan tube yang sesuai dengan usianya untuk masuk lagi sekali intubasi, dan Fogarty dijepit menggunakan cuff-nya dari balon tersebut. Gitu ya. Jadi mungkin bagi teman-teman yang membayangkan gimana cara kita one lung ventilation pada pasien neonatus terjawab ya. Jadi ada teknik seperti itu loh gitu digunakan. Jadi cukup menarik. This is my first time to know the technique. Okay. Yeah, maybe there is another question. Yeah. I'm sorry. I will pending dulu ya, because waktu kita udah terbatas. Kita mau lecture lagi satu, nanti baru kita mulai sesi diskusi lagi ya. Okay. We will start about the lecture from Dr. Lutilens. Okay. Udah gini ya. Reduce opioid consumption during the anesthesia and for the analgesia effect after the surgery. One of the most challenging case is the regional anesthesia in children, maybe is or in baby. Now we will continue the lecture our honoris guest, the excellent pediatric anesthesia, Dr. Luc Tillens, to share his experience about caudal or ilioinguinal block for the hernia repair. I will introduce you about the curriculum vitae.
Next one, this one, yeah.
Of Dr. Luc Tillens.
Thank you very much.
Okay.
Good.
Quickly. Yeah.
I'm Luc Tillens. I'm a pediatric anesthesiologist from Radboud UMC. Radboud UMC is in Belanda, and this is my city. It's a very small city on the biggest river in the Netherlands, and the Netherlands has a lot of rivers. It's in a delta, but this is the biggest river coming from Germany. This city is very close to Germany. It's about 10 kilometers, and I'm in another country, in Germany. It's a small city, but it's a huge university city. It has a huge tertiary hospital, also for parts of Germany, because in background in Germany there is not really a big city with another big hospital. So we are actually having draination of patients also from Germany into our tertiary university hospital. We have pediatric anesthesia because we have all specialisms in our hospital. Good. I like to start a little bit about the history. We are going to talk about herniotomy in children. What would be the best option to do to get these babies pain-free? Don't think that where we are talking about is already ages ago. It's just like 1986 that the first article showed us actually. It's not working. Do I need to do that? Oh yeah. That this article shows us that they were using caudals to block pain in these children, but at this moment there was an article that shows that ilioinguinal block provides a successful alternative to caudal block. So it's not like 100 years ago that we already did these blocks. But this is the start. Not that long ago. When do you think we started to do this ultrasound guiding things? How many years ago is that? 40 years ago? 20 years ago? Exactly 20 years ago, the first kid was injected ultrasound guided for ilioinguinal hernia repair block. That's just 20 years ago. That was the first. Doesn't mean that everywhere around the world, 2 months later, everyone was doing it ultrasound guided. So it took up till now that still we have to talk about what would be actually better. What can we do better? What is more evidence for? Right? That's how we work in medicine. There is a new invention, and then we have to see what will be better, this new technique or the old technique. And that's where we have a look at today. So nowadays, there is a continuous search for methods to relieve the pain. And there is a continuous search nowadays to try to do that with as low as possible use of opioids. We try to be opioid sparing. And in this new world of opioid sparing, we need to have techniques which we call local regional anesthesia. And these techniques should be safe, low incidence of side effects, reliable, effective. It should be working, right? And it should be working as long as possible. That's right, huh? We are looking for that within the whole medical world. As in the whole medical world, doctors are trying to do better and better for their patients. And we as anesthesia, we try to do that too. And we are trying to find good ways for pain relief, because that is one of our major concerns, especially post-operatively. And the technique should be simple. It should not be a very complicated thing. We were just talking about single lung ventilations in these small babies. That's very complicated. That's high-grade technique. But local region anesthesia should be simple, good to use, working properly, and safe, without later complications. Right? It should be safe without with a low incidence of side effects, but it should all be safe for complication. And the easier the technique, the less complications you will have. That's a fact, right? Good. Here somewhere. Next. There we are. Okay. The local anesthetics are used as a supplement to general anesthesia. We not really do local region anesthesia techniques in children to keep the baby awake. Like we can do a hand or elbow surgery, or maybe even a shoulder surgery under an interscalene block, and the patient can be awake. But that's not done in children. We do the interscalene block or the supraclavicular block or the axillary block for hand surgery, but the child is under general anesthesia. Worldwide, it's accepted to do regional anesthesia techniques while the children are sleeping. In adults, we are not really doing that because we need that patient also as kind of a monitor. The patient can show us that we might be with the needle too close to the nerve and he will feel paresthesias or even pain. And if we inject and the patient feels pain, we might inject intraneurally. And we can stop that injection because the patient says, I feel that. But if you put them asleep, this monitor is gone. But in children, how good will they be as a monitor? They can't explain you, I'm feeling tingling in my hand. I feel some tingling in my lips when you start the injection and the patient feels that. This kids up till 5, 6, 7, 8 years old, they can't explain to you. So how is this kid as a monitor? It's not the best monitor. But more important even, these kids, they are cooperative until they are not anymore. You can put them down and say, okay, stay still because I'm going to put a needle in. All the adults will shiver and say, shit, he's going to stick a needle in. What will this kid do? He runs away in advance, so he's not cooperative anymore. Maybe he is cooperative and stays there on the bed, and you put the needle in, the moment the needle goes in, he says, and he's moving. And you have your needle in there. That's not what you want. So kids, they are not the best monitor, and kids, they are not cooperative. So what we do is, we do these techniques under general anesthesia, realizing we're losing a little bit of the monitoring, but we have a stable situation without a moving target. Right? And we know all these epidurals. Do you do epidurals in pregnant women for the delivery? Some of these women can't sit still anymore. They are moving and they're having a contraction, and you are sitting there with your needle. Oh my God, this moving target. Huh? You realize that? Good. So, if it's a supplement to general anesthesia, it's also mostly because of a good postoperative pain relief. It's important nowadays. In nowadays anesthesia, trying to reduce your opioids, I should suggest every patient deserves a block. I had a discussion in the car with many. Are you going to the dentist? Do you want your anesthesia? No, you don't want anesthesia? Yes, we want anesthesia before he starts with something. Then why not your patient on the table needs an anesthesia? Yeah, he's in general anesthesia. Yeah, but if the general anesthesia is over, he relies on opioids to block the pain. Maybe some NSAIDs, maybe some paracetamol. But to block the real pain, we need a good block, or otherwise you have to rely on opioids. So this is really going to help you. But how? There are different approaches. For the inguinal herniotomy, there are different approaches. You can do caudal anesthesia, or you can do ilioinguinal, iliohypogastric nerve block. What are you doing here? What is mostly done? Caudal. Ultrasound guided or blindly? Blindly. Don't worry, I still have colleagues doing it blindly. I'm 20 years on the roll doing ultrasound guided blocks in kids, because I was the first, I told you 20 years ago. But they are still not doing it. For God's sake. But okay. Caudal or ilioinguinal? Let's have a look. Oh, this is the other way around. Right. In 1995, they wrote local anesthesia, which is the ilioinguinal block, and caudal anesthesia have similar effects. Slightly different things. Similar effect, this was the conclusion. Postoperative pain scores and opioid usage are similar. Vomiting times to first ambulation and first urine, the same. Meaning, to reduce the pain, they are both equal. About the side effects, they are both equal. Complications, oh, they didn't mention. What was different then? Well, in the ilioinguinal block, you needed a little bit more acetaminophen, paracetamol. But with the ilioinguinal block, they were shorter in the recovery, and they could go home earlier. So, a slightly disadvantage, you have to give the patient some paracetamol, but then you directly can send them home. An advantage. So it showed us that actually, yes, it's for both is the same. So which technique should we choose? On which base are we going to choose? There was nothing about the complications. Maybe the most important thing to choose is safety aspect. What is more safe? Which one is more safer than the other? Is there a difference? Should we choose for which kind of safety and which kind of complications? Or, okay, the side effects are the same, but maybe they are slightly different. One has this side effect more, one has that side effect more. What is happening there? If we look at the safety aspects, Guillaume, a French person, where is she here? Guillaume, she was in this very big investigation, but she's here again. She did mostly both. What they tried to find out was about complications and the differences between central blocks and peripheral blocks. And what they find out was, if you have a complication in a central block, the complication is more severe and leads to later, longer complication rate. So it's more unsafe for severe complication. If you do peripheral blocks, there will be complications, but the complications are less severe and having a less longer duration. So the recovery from what has been damaged there is better than if there is some damage or something wrong in the central compartment. So this should lead us little bit more to do peripheral blocks. These two investigations told us in the world to say, go as far peripheral as you can get for the safety of the complication problem. So if you have a hand surgery, you're not going to do an epidural. Right? Yeah? So you understand what I mean? Let's see for the caudal. We start with the caudal. What is happening there in the caudal? Suraj from America, very important man in writing a lot of things. He wrote this article about complications and things like that, and he said the overall estimated incidence of complications after caudal blocks was 1.9, like about 2%. Is that high? Is that a high complication rate? We think yes. As anesthesiologists, we think every complication is not good, so we want to have an incidence as low as possible. We cannot live with this high number of 2%. We might do something wrong for our patient. Do you know what is the complication rate of almost all surgery that the surgeons are doing? It's between regularly 6 to 10% complication rate risk. Do you think the surgeon's not sleeping about that? No, he just starts his operation. He knows there might be a complication, but that's how they live. Can we do that as anesthesiologists? No, we can't. We have 2% and we have to discuss about it and do investigations already for 10 years. How can we lower that? That's the differences. In his article, he shows us that block failure, blood aspiration, dural puncture, all kind of things because the needle is in the wrong place, are due to these 2%. But safety concerns should not be a barrier to the use of caudal blocks in children, assuming an appropriate selection of local anesthetic doses. Okay, so he is taking into his considerations also lost local anesthetic systemic toxicity. So if we do the right thing in the right place with the right dose of the right drug, we might not have that much complications. But still, these are there, saying nothing about anesthesia doses or anything. What is there can be lowered by the use of ultrasound. If you use ultrasound, you're going to visualize your natal position. You're going to visualize the spread of your local anesthetic. And if you see the spread, it will not be in a vessel. So you not only have to rely on blood aspiration. You might see blood aspiration, but if you don't see blood aspiration and you inject and you see your local anesthetic appear in your image in your machine, you definitely know I'm not in the vessel. Hooray! No loss. Block failure means, is my needle in the right space to block the right nerves? If I visualize where I am with my needle, I know that I'm on the right place. So the fear for block failure definitely goes down because success rate is going up, up, up by visualizing what you actually are doing. So the use of ultrasound can definitely lower these 2%, can lower these kind of things. And if you can lower these kind of things, the safety is going better and better. It's going to be more and more safe. Although there is still a side effect that it will be always there. You can't take away this side effect. If you do a central block up till T10, somewhere here, for sure the bladder is not working anymore. It's not having no sensitivity anymore. So he can't feel if he's full or empty. And that's why you need a bladder catheter when you do central blocks. And you cannot just wait, although we do that, until a certain moment. And now we can wait also because we have the ultrasound. we can scan the bladder. We can see how full it is. And if it's getting too full, you do your catheter. If it can pee before it's too full, you don't need the catheter anymore. Also, ultrasound is helping you. Something that appears all of a sudden, self-limiting back pain. It's happily self-limiting, but even kids in these small babies with caudal blocks, they can have problems with lower back pain. What do we do about it? Nothing. It's not for this reason that you say, no, I don't do any caudals anymore. But it's in literature. Is caudal with the ultrasound useful? The ultrasound is very reliable to show your needle position. A good needle position is essential for a good working of your block. If your needle is not in the right place, your block will not functioning. So you need for your success a good needle completion. You can use some saline to inject and see the spread of your saline before you inject your local anesthetic to know that it's in the right place. I'm not doing this because if I see my needle is in the right place, I know if I inject saline first, it's diluting my local anesthetic even more. So I want to keep it just local anesthetic to inject. And I adjust the concentration for the volume that is needed in that little patient. It's very good for complication control. Which complications are there? Are I intravascular? Am I not in the right place? Am I in the dural sac? Where is my needle? I can see him. I know where he is. And it's easier to identify the target. Sometimes you might try to feel the cornea, and in about 20 to 30% the corneas are not really palpable. And if your corneas are not palpable, you don't know where your needle has to go to. But if you can put the ultrasound there, you will see it from the inside. Where are my cornea? Where is my sacrococcygeal membrane where my needle has to go into? And if you can visualize it, for sure your needle goes into the right place. So, about the technique, you first scan transversal and you will see the corneas. You will see the corneas with the black shadowing underneath bone. And then you see here, have you ever heard about scanning the neuraxial column, the vertebral column? You try to find that looking through the intervertebral space, and then you see the anterior complex. Heard about that? The anterior complex is actually the anterior side of this vertebral column channel. The channel where is in the epidural space and the dura mater with the cerebrospinal fluid and the myelin inside. Right? So if you see the anterior complex, this, what you see here, is os sacrum. This is also os sacrum, but this is the dorsal part and this is the ventral part. And between the ventral part and the dorsal part, here, this is epidural space. And what is this double layer here? This double layer here, one line, two lines in between. This is my sacrococcygeal membrane. My needle has to go through that membrane into this gray area. But am I doing it like this out of plane? No. I turn it this way. You see the drawing on the patient, Vincent van Gogh. I came from the same village. I could really draw nicely, right? Don't you think so? Really nice drawing. Now you see here the cornea. You see coccygus. You see this spinas iliac posterior inferior. In the triangle you will find the corneas, and in the middle you should put your needle in 40 degrees inside, and then you feel some resistance, and then you lower it a bit down and you push it a little bit forward. Where are you going to? Do you know? Okay. How does it look like? If you twist your probe from this position to the 90 degrees position in this sagittal plane, you will see this. That's anterior process, anterior complex. This is os sacrum. And then here, this is posterior os sacrum, and this is anterior os sacrum. Posterior os sacrum has one ligament going down to coccygus, and from the outside and from the inside. And in between here, there's a double layer, a gray double layer. This is your sacrococcygeal membrane, and this black gray is all epidural space. So my needle has to come from here, going through this sacrococcygeal membrane into this grayness. It looks like, can we run this one? Can you run this one? Can I do that with here? There we go. Let's have a look. Is this bone? Whew, there are two eyes. It looks like frog eyes. That's a frog. Two eyes. There's a double layer here, blackness. And there's an anterior complex, os sacrum venter. I twist the probe 90 degrees, posterior part, anterior part. You see the anterior part first, and then you see the posterior part, and there is my double layer. The needle comes on top of the double layer, plop, inside this grayness, and there's my needle, in the epidural space. Easy to find, easy to see. But I definitely know my needle is in the right place. If I put local anesthetic in here, this caudal is going to work. Right? Can you put the next slide? This is a bit injection of local anesthetic. Let's have a look at the next slide. Is this the next slide? Yeah. No, it's the same. I think this is the same. No. This is the next slide. Now you see here, the needle is already there, but it's past the last S5 spinal. So I want to withdraw it a little bit. And now what I'm going to do is looking upwards, 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 upwards. Oh, there you see. What is this? This is caudal sac, meaning this is dura mater. And this is dura mater. And in here you see a little bit of, that's by dura mater pushed down by this blackness. What is this blackness? The dura mater is pushed down on the cauda equina. And this space is filling up with blackness and pushing dura mater downwards. Meaning there is some fluid going into that epidural space, making space by pushing down dura mater on top of the cauda equina, and all in the end up to myelin. And this space is filled up with the fluid I'm injecting, local anesthetics. So I'm filling up epidural space. Yeah? Can we have the next slide? If you have a look higher up, like this level somewhere here, you might see the myelin. And then we do a transverse visualization of what's going to happen. There is my myelin. It's like a kind of a butterfly. And here is cerebrospinal fluid. This is my dura. Did you see this space appearing, filled up with local anesthetic? So I can see my needle placement is through the sacrococcygeal membrane. It's into the epidural space. And if I do my injection, I see the epidural area expanding with local anesthetic, pushing dura mater on top of the equina and on top of the myelin, filling up epidural space higher and higher. Right? Next slide. So, should we use ultrasound? Yes. This sacroiliatus is clinically identifiable only if the sacrocornea are palpable. If you can't feel the cornea, where's your needle going in? Blindly somewhere? But ultrasound will always show you, no matter if there's a fatty baby or there is this dimple thing or whatever, you will find them with the ultrasound. So you will know where your needle has to go to. And since you can't feel it, you need the ultrasound to visualize it. It's essential. Another conclusion, use of ultrasound, it reduces the complications and increases success rate. That was part of this 2% that Suraj wrote in his article. So the ultrasound is definitely raising success rate and lowering complications. So even this 2% is less than 2% while using ultrasound. Good. That about caudal. Now see what it's doing ilioinguinal. I showed you the study of Geoffrey, and they are telling us that we should use as much as possible peripheral nerve blocks compared to central blocks. So this is an advantage in the way of doing maybe better ilioinguinal compared to caudal. But is it the truth? We did this always landmarked. Some people called it a double plop. You put your needle in the skin and then you should do plop plop, and then you are through external oblique muscle, internal oblique muscle, and so you are on top of transverse abdominis muscle. And that's where the nerves are. So then you just inject and your block will be working. Perfect, double block. Problem is, there are some complications. 20 to 30% has a failure. You are not in the right place and the block doesn't work. How can you explain that? Yeah. I'm going to do anesthesia for your baby. Tell the parents. But we will do a needle technique somewhere there. 30% might not functioning. That's not nice. That's not what you really want. You want to do something that was safe but also reliable and effective. So doing it blindly is not really effective. On the other hand, there was a bowel puncture. You couldn't see or feel if you were going plop plop through all the muscles and through the peritoneum into the bowel of this patient. The problem in this patient was this bowel puncture made the mucosa bleeding, and the mucosa bleeding due to a ischemia of that part of the bowel, and they had to take away 20 centimeters of intestinal. So this complication is not what you want anymore. But this was blind. Now we can see. So why don't we look? Inadvert femoral nerve block. We did spinaliac anterior superior. We go 2 centimeters in, 2 centimeters down. That's very close to where the vessels, but also femoral nerve is going through this abdominal wall into the leg. So if I put a lot of local anesthetic there on top of transverse abdominis muscle, underneath internal oblique muscle, it's in between the muscle layers. If there are 2 small nerves, ilioinguinal, iliohypogastric walking there, but a little bit further there is another big nerve going through these muscle layers, there will be outer space of this femoral nerve will be blocked by a little bit of local anesthetic that might spread there. And this little bit of local anesthetic might block the outer side of the femoral nerve. And the outer side of the femoral nerve is the first fascicles that go out of the femoral nerve into quadriceps. And the first fibers going out is medial vastus medialis muscle. What is this muscle doing? Keeping your knee inside. So if this muscle is not working and you stand on the leg goes like that, and the boy is laying down on the floor. Everybody in panic. Oh my God. He came for a hernia repair and now he has lost the power in his leg. No, it's the block. It's in about 9%. Do we explain all the parents that if we do a block, realize that your kid might have a leg that doesn't function that well, but it will come back? Not everyone. So, is ultrasound useful in the ilioinguinal block? Is it useful? Well, this study is the first study of Wilske and Marhoeven already in 2005 that they wrote that it is very, very useful. They did 100 patients and they saw such an amount of analgesia lowering down dosages, postoperative rectal acetaminophen 6% versus 40%. So actually, they have a very high success rate, and they could lower the total volume that they were using. So they showed already in 2005, the use of ultrasound is very useful. They did the next study, and they were trying to find the dose that they needed to use. It was about 0.3 milliliters per kilogram, and they could lower the dose to 0.075 milliliters per kilogram. How much is that? That means that if you have a baby of 10 kilograms, you not even need to use 1 ml, you only use 3/4 of a milliliter. I was doing this in the same period of time, trying to invent what is really possible. I was trying to find these nerves. They saw in 10 patients all the 2 nerves. I never really saw them, but I knew they must be on the plane, so let's just inject 1 ml. And I called all these parents afterwards, 30 or 40 parents, and they said, no, he's no pain, he was perfect. Yeah, we give him some paracetamol. Oh, why did you give paracetamol? Yeah, the surgeon says you have to do that. But he has no pain. No pain. Okay, very good. So I already realized 1 ml is sufficient. But they said, no, you don't even need this much of amount. You can lower your dose, less lost. Then this study was done. Blindly, they put the needle in, plop, plop, they inject, and then they go out, and then someone else came with the ultrasound. Let me see where was this local anesthetic injected. Then you see that only 14% was in the right spot. 14% was exactly in between transverse abdominis muscle and internal oblique muscle. Most of them were in transverse abdominis muscle or in internal oblique muscle. Some were even deeper, some were even more superficial, and some were totally ray. But this light gray shows that even if you are in a little bit deeper in the muscle or a little bit superficial in the muscle, that mostly these blocks will still function. Hooray! But here you see why it's only 20 to 30% failure, so only 70% success rate. Ultrasound can show you where you have to go. You have to go between the muscles. But then this study comes and says, oh, be careful, because between the muscles there are also the vessels. And if you inject local anesthetic close to the vessels, the uptake into the central compartment might be very high and quick. And yes, they showed us that the uptake is higher and faster. But if I inject just 1 ml in a 10K baby, would that be a problem for lust? If I'm following the guidelines from Marhover and Wilske, I would only inject 0.75 ml. That definitely is not a problem for lust. So you can just inject that 1 ml. You can even inject 2 mLs. Even if you use ropivacaine 0.75, you are still under the toxic dose. And realize this is a nice study, but it doesn't bring us anywhere. It's showing us, yes, the uptake is bigger than normal if you inject in planes. And yes, in overall local anesthetic techniques, we are going more and more to plane techniques, although nowadays it's a bit changed and we're going to leave the plane techniques, but that's something else, and that's another talk. But this study, 2009, Ford showed us actually, Wilske and Marhover showed us that in 2005 they could see in 100 patients all the two nerves. I couldn't find them. I just injected in the plane. Didn't know what I was doing. Yes, somewhere they must be there. But finally, I was very happy because in 2009 he wrote that you just inject in the plane. They are there. Just do it. I did already, but that was experimental. Oof. But now I have coverage. So you just inject in the plane and you will get your block. That was the first explanation of a plane block, by the way. Then there came some new techniques. We are not going from the sphenoiliac anterior spine 2 centimeters in, 2 centimeters down, very close to where the incision is, and the surgeons always tell you, oh, not too much fluid because I can't see my anatomy anymore. This technique shows us that if you go a little bit upwards, that you see the 3 muscle layers, because downwards this external oblique muscle will be aponeurosa. External oblique muscle is below the nerve, below the umbilic is an aponeurosa. It's only a white line, a thick white line. So you will only see 2 muscles if you go low. If you go up, you directly see external oblique muscle opening, and when external oblique muscle is opening and becomes a muscle, instead of only an aponeurosa, you will see the line in between internal oblique muscle and transverse muscle much better. And it's in this line where, okay, they show here 2 nerves. This is 1 and that is 2, or this is 1 and that is 2, or yeah, okay. They show us 2 nerves. I'm not really interested in seeing these nerves. I want to see that plane. And if I see the plane, I bring my needle in the plane, make sure I'm in the plane, I inject a little bit, it becomes black, I'm between the muscles. I inject 1 ml, maybe for sure 2 ml. In former years we injected like 3 ml. And lower. Now we are a bit higher. You can do that. So the use of ultrasound increases the success rate. There is less failure. So the first, where we were afraid of, is okay, there is a failure rate of 20-30%, it's gone. There is visualization of the needle position, so there's no intra-abdominal needle placement anymore. If you work nicely. If you still don't look where your needle is going with your ultrasound, just push it in, oh, I'm too deep, I'm intra-abdominally, you're not using the equipment the right way you should do. But if you do it the right way and you show your needle and every advancement of the needle is seen in your image, you know where your needle is going to. And if it's going a little bit in the direction of the intra-abdominal area, you should stop pushing it forward. Right? And there's less femoral blocks because we are further away from where the femoral nerve goes through the abdominal wall. So we really don't see this anymore. So what about all the complications? They are gone because of the use of ultrasound. What did I just explain about caudals? There is an incidence of complications, there is an incidence of side effects, but with the use of ultrasound, they can be lowered. What about the complications in the ilioinguinal block? They can be definitely lowered by the use of ultrasound. One extra thing. There is new anatomy known. New anatomy? Yeah, new anatomy. What does it tell us? It tells us that the ilioinguinal nerve can also come from T12. It can come from T12 and be together and be the ilioinguinal nerve, iliohypogastric nerve. So it's not only L1. It can be T12, can sometimes be L2. But it comes from T12 as the highest. Is that important to do ilioinguinal block? It doesn't matter where the roots are, as long as somewhere in the peripheral area I'm going to block these 2 nerves. Then it doesn't matter where they come from. But if I do a caudal block, and I want to have a block only till L1, then maybe some fibers from T12 can still feel the pain, because you didn't block it. So you need for a caudal block definitely a block till T12. Otherwise, it will be maybe still having a failure. So this is new anatomy that's important for caudal block, not really for the ilioinguinal block. Let's have a look of the technique, ilioinguinal block. You put the probe, spina iliac anterior spine, and then you push it, you rotate it a little bit to the umbilic. So the probe is on spine, spina iliac anterior spine, and then you rotate it a bit to the umbilic. Then you look through the abdominal wall. And what do you see? You see aponeurosa, that's external oblique muscle. You see internal oblique muscle, and you see transverse abdominis muscle. And transverse abdominis muscle is like halfway here, because transverse abdominis muscle is walking in the body like this from my side, meaning the lower you go, the further it will be away from the midline. It will be going to the peripheral area, meaning you don't see it as a stretched layer underneath all the other muscle layers, but you see it as like a banana. And there are some vessels. And my needle should go there, close to the bone, between the vessels and the bone. My needle comes from medial to lateral, because if I go too deep, I will hit the bone. If I come from lateral to medial and my needle goes too deep, I end up into the abdominal area. So for safety, my needle comes from here. How does it look like? Can you show the video? There we go. Aponeurosa, a little bit muscle. The needle comes in. Internal oblique muscle, external oblique muscle. The needle pushes through, and then plop, it's in the line. Poop. You saw the plop. Let's find our needle back. Where is the point of the needle? Try to find it again. Oh, there it is. There it goes. It's not. Oh, there it goes. More. Oh, there it is. It's still in the muscle. You see? Now it's getting into the layer. And the needle point, whoop. Is it? There it is. There it is, in the layer. Poop. Out of the muscle and in the layer. Inject a little bit. And what is that little bit doing? It's making blackness. Pushing up this muscle up. And there is the other muscle. So there's a lot of blackness coming in between. And this blackness is my local anesthetic that I inject in this patient. And it's in between the two muscle layers, so it's in the plane. Because if you inject in the muscle, it will disturb the muscle and it will become gray muscle. And there will be more resistance. And it's this one, whole lake of local anesthetic. This is 1 ml. What? Yeah. It's a lake. Woof, 1 ml. If you do half, you look like a... Right? It's 1 ml. Not that much. Sorry. So, important to understand. Do we do caudal or ilioinguinal? What are we going to do? Oh, we do both. Let's do both. Nice study. 2009. What did they do? They did a caudal with an ilioinguinal block or a caudal without an ilioinguinal block. What did they see? With the ilioinguinal block, the pain relief was much better than the caudal alone. So are we going to do both now? The response to this article was one we had in my hospital as well. My colleagues and I were looking at it and said, whoa, what happens here now? Why is this? If you do a caudal block, it showed that you had to have a block till T12. How do we get to T12? Inject it there? No, we inject from the bottom. So what do we need? Volume. They were using bupivacaine 0.125%, 0.7 milliliters per kilogram. What does that mean for the caudal? How high will be this block? What do you know about that? How much do you need in the block for a caudal? There was one thing I always remembered. It's from Dahlens, and that's the formula of arbitrage. And Professor Dahlens is from Paris. He wrote this thick book about local region anesthesias in children. I spoke with him. Whoa. He was the godfather that time. He wrote a very big book, but everything without ultrasound, because he was an old man. He was already retired when I spoke him as a resident 20 years ago. So, right? But he learned me this formula of arbitrage. You use bupivacaine 0.25, Nowadays you can use ropivacaine 2 milligram per meter, 0.2%. You need half an ml to fill up S segments. It's wrong, it's from L5 to S5. Here it needs to be S5. It means, or there must be an S, S5 to S1. It means from below you fill up a certain amount of space with a half an ml per kilogram, means you fill up from S5, 4, 3, 2, 1, the S segment. Then you need another half an ml per kilogram to fill up this S segment plus the L segment. You cannot just inject and say, okay, I want to fill up from down here somewhere these L segments, L1 to L5. No, you first have to fill up S segments and then the L segments, and then even a little bit more. So half an ml is for the S segments. Sorry for my fault, this needs to be an S. And 1 ml to fill up S and L segments all the way till T12. But to make sure T12 is in, you can even use 1.25 ml per kilograms to go till T8 or 9. But if you use 0.7, for sure you're somewhere here in the middle. You might not have reached T12. So yes, if you do these caudals, the caudal alone might not function in all babies, and they might have pain. And in the group that you do an ilioinguinal block extra, yes, for sure, the ilioinguinal block will block the pain. But we are not going to do both together. We do both properly, but one or the other. Good. So, what is actually the conclusion? It depends on safety. I think I showed you they are both more and more very, very safe techniques if you can use ultrasound. If you don't use ultrasound, they are not that unsafe. Suraj showed you. You can still use it. Don't be afraid of these 2% complications and then say, oh no, I don't do this block in my babies or my patients on the table. He is encouraging you to just use it, even without ultrasound. Use local regional blocks. Complications and side effects. Yes, they can be lowered and lowered and lowered and be very, very low incidence by the use of ultrasound. But without, still do blocks. Or should we use other blocks? Should we not use these blocks for the ilioinguinal hernia repair? Should we use other blocks? Which one? Caudal. Ever heard of it? It's a block done for abdominal wall. Abdominal wall. And it's done all the way here in the back. And abdominal wall is like T6 to T12, right? What is happening here all the way in the back? If you look up to the abdominal wall, the umbilic is T10. So my T10 nerve ends up here somewhere. Where did it came from? Here? No, my T10 is here. That's my ribs. So T10 comes from here and goes down there. That means if I go from here, T10 in the center, to lateral, there's here somewhere is T11. If I go even further laterally, there will be T12. If I go further posteriorly, there will be L1. And if I go all the way to the caudal to the back, there will be L2. Feel my ridge here. Where do I do my spinal injection? L2 to L3, somewhere here. So if I put a needle just beside that, through my caudal to the front of the plexus, it's actually plexus lumbar block. And of course there will be L1, 2, 3, 4 in blocked if I use a lot of volume. So if I do a proper caudal block all the way in the back, around L2, L3, there might be L1 blocked too. And yes, for that, it can be used for ilioinguinal herniaectomy. But then, remember what I said. Is this simple? Is this a simple block? Caudal is much more simple. Ilioinguinal, much more simple. This is a deep block, difficult to find. And you are blocking the whole lumbar plexus, so the leg is sleeping. Caudal lumborum block is described as an abdominal wall block, but it is used for hip surgery. Why? Because it's a plexus lumbar block. It's perfect for hip surgery. And this was all coming from Jens Berglund. Jens Berglund described this all about the Caudal lumborum block. The last time I spoke with him in the Ezra in Prague, Czechia, he was actually, yeah, Luke, you're right, yeah. We talked about that a long time ago, but yeah, I need to say, yeah, maybe Caudal lumborum block is not that good for the abdominal wall, but it's definitely good for hip. I said, yeah. We talked about it, but why did you change this? Yeah, it can be used for abdominal wall blocks because there will be some spread upwards. But the security of the spread upwards might not be 100%. And this is the problem with plain blocks nowadays. ESP block, oh, perfect for everything. No, maybe only for abdominal and chest wall, but maybe not for the inside. You should listen to Manush Karmaka, a very important man in these studies things, in doing central blocks with ultrasound. He wrote a comment about all these plain blocks. He is telling us, go back to the real nerve blocks. This is something too. Should we do this? Complication things needs at least a lot of volume. It's a risk. I should not really recommend it, but it can be done, even compared to a tab block. A tab block might also block L1 fibers if you do it here, a little bit less posteriorly, a little bit more laterally. There will be still L1 fibers being blocked. And it's the L1 fibers that you need to block ilioinguinal, iliohypogastric blocks. But a tab block, more complicated than ilioinguinal block. Needs more volume. So it's not the simple one. Retrolaminaire block. Retrolaminaire block is a side block like ESP blocks. Yes, can be used. Yes, of course, you can take the fibers there. Complicated. Volume. Why using this if it can be more simple? And yes, these also have very low incidence of complications, these blocks. Caudal lumborum has complications, but this one, retrolaminaire block, tab block, less complications, but it's still complicated. It's still more difficult to find the right spot. So, this is definitely done very well with the use of ultrasound. The simple thing and the less complication should bring us to use a caudal block or use an ilioinguinal block. So why do I decide what I will do? What do I decide? Which one? If it's both sides, I will definitely do a caudal because it's just one injection for both sides. If it's not a hernia to me, but it's an orchidopexy, I can decide for a caudal because the testicle and the scrotum are in the same caudal block. While for the ilioinguinal block, it's only the incision and the inguinal channel. But if it's just one size ilioinguinal hernia to me, ilioinguinal block would be my choice. But it will be my choice because I know both techniques. But it's in your hands. And safety is not only because I know, oh, this block is safe, but is it still safe also in my hands? Am I experienced to do a caudal block? No, never done it, but it showed me that it was very safe, so let me try it. That's also, safety is also your experience. So where are you used to work with? Which possibilities do you have? And if it's more difficult, can you still have the possibility to use an ultrasound to visualize your pathway of your needle? And if not, maybe you should decide, okay, I can't really feel anything. I can't see it with the ultrasound because there is no ultrasound. Maybe we do an ilioinguinal block. But it's also without ultrasound, so that's plop plop. So there's not really a choice to make, except there is only one thing: use a local region anesthesia technique. And the use of local region anesthesia technique is extremely important nowadays for pain relief in our children. And with the right knowledge that you have and the experience, both techniques can be effective and very safe. Although pediatric anesthesia is very, very dangerous.
Okay, thank you to Dr. Lutfilens for the interesting point of view of this new topic.
Bit too long, huh?
Now, because we have limited time, I will choose two question for this section from this room, and maybe we will choose in the live streaming of YouTube just one question. Jadi untuk teman-teman di sini, saya persilahkan untuk di sini dulu untuk 2 orang, mungkin dari satu Felix, satu lagi ada yang mau nanya. Nah, jadi 2 orangnya kita akan persilahkan untuk bertanya. Mungkin di sini ada Dr. Felix terlebih dahulu. Dr. Felix untuk Dr. Tilens, oke.
Good afternoon, Dr. Tilens. I am Felix from the 4th year resident in here. First of all, thank you for coming and sharing with us. I want to ask a few questions to you. The first is, what's your experience doing neurological anesthesia, especially spinal anesthesia, for surgical procedure in lower abdomen for baby or infant? Are there special any considerations for spinal in baby or infant?
Yeah, spinals we actually only do in neonates. Because doing a spinal in a sleeping patient is kind of a risky thing, and RDS, we give the pulmonary problems. It has been intubated in the neonatal ICU. It is extubated, and now it needs, for example, an ilioinguinal hernia repair, maybe on both sides, and you need to do something. If it's this patient that has a vulnerable lung, we don't want to have any interference with the lungs. So we don't want to have an intubation, not laryngeal mask, not positive pressure ventilation, because it can go backwards into ventilation and in the NICU. So to avoid that, we do spinal anesthesia. The older the kid, it's not really for use, because it's also very very short duration of the block. If you look at the cerebrospinal fluid production in kids, it is twice as high as in adults as in us, meaning the turnover of cerebrospinal fluid is very high, meaning the wash out of your local anesthetic is very quick, meaning the block will be lasting maximum half an hour, maybe 40 minutes, 45 minutes, but that's maximum. Meaning if you do it in the kid, you need to have the surgeon ready, washed and ready to start. Because you do the injection, the baby has the spinal anesthesia, he has half an hour to operate and close. Not many procedures are sufficient for that. Even a double-sized ilioinguinal hernia repair is told me that you could do that with a spinal, but have 2 surgeons ready. Because which surgeon is doing this ilioinguinal hernia repair both sides within half an hour? In my hospital, we do 1 size in half an hour, but we are teaching hospital, and some of my surgeons said, yeah, but if I'm working in the other hospital, it's going much quicker, blah, blah, blah. I don't rely on that. If you see the operation time, it's minimum half an hour and always more. So you need to understand, it is really only for the patients that has lung problems to avoid any airway management. It is very short duration, so you only use it sometimes. You understand what I mean?
Oke, ada lagi lanjutannya dari Felix.
It's not working. It's not
Eh,
working.
mic-nya tolong dibantu. Ada cadangannya mungkin. Ini tunggu sebentar biar masuk untuk di live juga. Jadi tunggu lo mic.
Okay, Dr. Tillens, thank you for the explanation. And I want to ask the second question about the peripheral nerve block in a baby or neonates. Do we have to use the hockey stick probe for the blocks, or we can do with the high frequency linear probe as we do in usual? Because in our hospital we haven't got the hockey stick for the peripheral nerve block in baby. And any pitfalls for doing the peripheral nerve block in a baby or infants different from the regular adult patient? Thank you.
What do you think I would answer about the hockey stick? Huh? I started all the techniques with just one probe, and that was the regular adult probe, because there was no hockey stick when I started. And finally, when more and more colleagues were using it, they were complaining and said, look, why is this probe so big? We need a smaller one. And then they came up with a hockey stick. But in my opinion, every patient deserves a block, even if it is with a huge convex probe. If you can show the nerves for yourself, you do the block. Understand what I mean? So I know there is not in every hospital a hockey stick, but you can do it with the regular big probes. You can. It costs you a bit more training, but you can see everything what you need to see to do a ultrasound guided block. And you saw me using these big probes too, even not the hockey stick. So it can, but these movies are made 2000 and what was it, 9 or 7 or what was on the slide? They are old already. But what I need to say, pops up in my mind now, is that most important in pediatric anesthesia is the dose. It's all about dose in pediatric anesthesia. It's of course with the ultrasound the right place to put your dose, but it's the dose that matters. And you should be aware of the fact that you never go above the maximum dose for that patient at that moment on your table. And you can have a baby for 10 kilograms on your table. We know that for bupivacaine we can use 2.5 milligrams per kilogram, and for ropivacaine we can use 3 milligrams per kilogram to be below toxic dose. You should make a calculation before you start. If I'm going to use, for example, bupivacaine 0.25, I can use 1 ml each kilogram. So if this baby is 10 Ks, there should be not more than 10 milliliters in my syringe. Making sure that even if I use everything, I'm still on the maximum dose. And I'm not going above. So that's for every kid. If you do anesthesia, count it for yourself, make the calculation, how much can I use in this baby, this moment on this table? And never put in your syringes that you are going to use more than this maximum. Then you never go over it and you never make a last local anesthetic systemic toxicity. So that's very important consideration in pediatrics. And yes, in adults you put 30 ml of ropivacaine 0.75, it doesn't matter. But in kids, it matters. It matters. Yeah? And if you want to use more volume, for example in caudals, you need more volume, dilute it. Dilute your maximum with 2 or 3 mLs extra of saline, and you have your volume to reach T12, for example. But since we use ROPI 0.2, you may use much more volume before you are toxic, 3.0 milligrams per kilogram. So you can use quite a lot of volume. Yep.
Okay, thank you, Dr. Tulfilans, for the explanation.
Cek. Apakah ada satu pertanyaan lagi dari sini? Ada teman-teman diberikan kesempatan bertanya? Oke, ya, Dr. Gin.
Thank you, Dr. Luke. It's a great presentation. I'm Gin from the second year's registrar here. So we know that the surgical technique is developed, so we should chasing them, right? In here, in your presentation, we're talking about the herniatomy with the ilioinguinal block. So the pediatric surgeon here usually use a laparoscopic way. So they expand the abdominal cavity with the gases. So that's mean our blocks is much wider, larger. How about your experience using ilioinguinal block in a laparoscopic way or any other technique locoregional that can coverage the pain management for this technique of operations? Thank you.
Can you show me on your belly where the surgeon is going to enter the abdominal?
Usually they use a small probe with a needle, usually here, and then expand the gases and use needle again to make a knot, and then they will knot, and then they will cut the hernia.
Yeah, but that means they go inside everything below umbilic, right?
Yes, but
Yeah.
the gas will expand higher than the umbilical.
Yeah, right. Everything below 10 can be hurt, right?
Yes, of course.
Don't talk about the gas, because that's something I'm going to explain you now. Ilioinguinal hernia, ilioinguinal block is an abdominal wall block. If the surgeon makes the incision, there's no reaction. If the surgeon goes into the ilioinguinal, there's no reaction. The moment he's taking the sac, that's peritoneum. It's not blocked. But the patient is under general anesthesia. And you put them under general anesthesia. Mask ventilation, put the IV, little bit fentanyl, he accepts the laryngeal mask. And so the saver and a little bit of fentanyl is also blocking the pain for pulling peritoneum.
Yeah.
I don't need a block for that, because the moment the surgeon has cut it and it's back in the abdomen, it's there. Then the wound is the one that hurts. But
Yeah,
the wound
just
can be blocked by ilioinguinal block.
Yes.
Now you want the caudal, and if it's laparoscopic, you need a caudal till T10. So you definitely should use 1.25 mLs each kilogram to make a block till T10. But why should you make a block till T6 while the kid is under general anesthesia? And the moment they are out and the gases is out, that extension is gone, and the pain or the discomfort that the patient might have of that is also gone. So why should I make a block this high? It doesn't need for postoperative pain. It needs postoperative pain from T10 and lower. So intraoperatively, happily, we have them in the general anesthesia. That helps us to block these moments that the surgeon is touching the peritoneum. And that hurts. But afterwards, we don't need it anymore.
Okay, thank you.
Oke, mungkin saya sedikit menjelaskan untuk yang tadi Gin, di kita sini operator menggunakan laparoskopi. Jadi mungkin pertanyaannya apakah kita memilih ilioinguinal atau caudal gitu kan. Dari Dr. Lutz juga menjelaskan bahwa yang terpenting adalah di saat insisinya, karena ketika melakukan manipulasi untuk menutup sakusnya, pasien masih dalam kondisi general anestesi. Ya, jadi sama seperti kita melakukan pemasangan infus, intubasi dan sebagainya, dia masih dalam kondisi general anestesi. Jadi ilioinguinal masih bisa dikerjakan pada kasus-kasus walaupun tekniknya berbeda, tidak hanya open herniotomi tapi juga laparoskopik herniotominya. Ya, gitu ya. Oke, mungkin terakhir ada satu pertanyaan lagi sebelum kita tutup sesi diskusi. Kira-kira dari teman-teman di sini ada Yang mau bertanya dulu kita berikan kesempatan yang di sini dulu. Kalau nggak ada mungkin kita akan bacakan yang dari ya YouTube satu lagi ya. Kalau di sini sudah tidak ada yang bertanya. Mungkin kita tidak bisa menjawab semuanya, jadi saya rasa saya akan pilih salah satu pertanyaan. Mungkin terkait dengan anatomi. Okay, maybe there is in our life there is a question from Solo. Johnny from Solo is asks how to monitor the effectiveness of caudal block or ilioinguinal block in children after the surgery. How it's maybe how we know the block is successfully done after the surgery. From Johnny from Solo.
You cannot measure if the block is functional or not, because you cannot ask the patient, where do you feel the numbness? But you can see the patient in the recovery room. If you did a caudal block and the patient is just there having his herniatomy, one size or two size, or laparoscopic or not, and it's not crying, why shouldn't you think my block is functioning? Would it be because the surgeon didn't do this much of pain to this patient? No, it's because your block is functioning. So we cannot ask these patients, can you tell me if you do a block, if you can move the arm or not? No, because these babies don't react and they don't respond to your questionings, so you don't know. But the fact that they are comfortable in the recovery room should be for you the results is from my block. If you really want to know, you can do ilioinguinal block. You put the patient asleep, mask ventilation, save a frame. Put the IV, but don't put anything. If there is enough save a frame, he will accept laryngeal mask. He keeps on spontaneous breathing. You lower the save a frame. You do the block. You start the operation. The moment they cut the skin and there is no reaction, your iliohypogastric nerve is blocked, because that's the skin. If they go deeper and deeper, coming into the iliochannel, and there's no reaction, your ilioinguinal nerve is blocked. And then they go to the sac and they will react. So it's not really nice to wait till the patient will react, because he will react. Peritoneum is not blocked in your ilioinguinal block. So you can wait. The skin is open, the channel is open, they are looking for the sac, and then you said, okay, I have seen no reaction, my ilioinguinal block is working, because only on safer frame he will react if you have non-functional block. That's just to make sure, okay, my block is working. Then you give some fentanyl to make sure that it's not going to react while he's taking the peritoneum in his scissors, what is it, clamp, and then you know it works. But I will just tell you, go to the recovery room, have a look there. I am most of my time during my working days on the recovery room. Yes, I do my anesthesia intraoperatively in the operation theater, and I do my blocks in the operation theater, but I have an anesthesia nurse always beside me, and in my hospital always a resident. So I can walk away and look at the former patient. And why am I looking in the recovery room? Because in the recovery room I can see the results of my anesthesia. And my big important part of anesthesia is the postoperative pain of my patients. And how do I know that I was successful? Go to the recovery room. Have a look there. How is my patient? Is the patient crying? It's a baby. If he has a hair in his eye, the only reaction is crying. If he is cold, he will cry. If he is hungry, he will cry. If he has pain, he will cry. So the moment you come into the recovery room and your baby is crying, but you did a block, or even didn't do a block, you first have to definitely know that all the rest is turned out. So give him the bottle with milk. If he stays with a bottle of milk and he's quiet and he drinks all the bottle, he was not really crying because of pain. If you give him the bottle and he's and then leave it and cries, it's maybe because of pain. Maybe because his leg is in between the bed somewhere. Oh, my block is not working, and then his feet is stuck somewhere. Yeah, can. But you realize you have to check the kid and have to check why is it crying. Because the only reaction it has is crying. So make damn sure before you say to yourself, oh shit, my block didn't work. Most blocks will work. But there might be more problems. Huh?
Yep. Jadi dari pertanyaan tadi, bagaimana kita mengevaluasi kesuksesan blok kita pada pasiennya setelah dilakukan operasi. Jadi dari Dr. Tilan sudah mengatakan bahwa tidak seperti orang dewasa kita bisa mengetahui keberhasilan blok kita melalui evaluasi. Tetapi pada faktanya adalah pasien-pasien pediatrik selalu menangis gitu. Jadi karena kedinginan dia menangis, dia lapar, dia ketakutan, dia menangis. Jadi dari Terluk menyarankan bahwa buat pasien itu senyaman mungkin terlebih dahulu kita misalnya memberikan susu atau minuman pada dia, kita lihat responnya. Ketika dia tenang, nyaman, berarti blok kita bekerja dengan baik gitu. Habis itu yang kedua juga di intraoperasi kita mau melihat, kita bisa melakukan, tapi kita menggunakan GA pada pasien-pasien yang pediatrik tanpa menggunakan analgetik. Cuma itu kurang etis. Jadi Dr. Luke lebih senang melihat postoperatif, hasil postoperatifnya daripada intraoperatifnya. Kita bisa melakukan di intraoperatif, misalnya kita tanpa analgetik, kita lihat ketika di insisi, ketika masuk ke channelnya, ketika mengikat sakus, ketika dia ikat sakusnya itu pasti akan nyeri karena tidak ada terblok oleh ilioinguinal. Tapi itu kurang etis, jadi lebih baik kita mengevaluasi pasca operasi di ruang postoperatif. Okay, we will thank you to Dr. Luke Tillens for sharing this invaluable knowledge on this topic. Let me to make a conclusion in bahasa maybe to involve my friend. Oke, untuk pediatrik regional itu bertujuan bukan hanya untuk menciptakan kondisi di mana pasien itu bisa kita operasi tanpa kita lakukan sedasi atau GA. Jadi tetap pasien-pasien pediatrik itu tidak kooperatif dan harus digunakan general anestesi. Tetapi kita ingin membentuk di mana kita menghadapi rasa nyeri pasca operasi sehingga pasien-pasien pediatrik itu merasa nyaman. Jadi konsepnya yang pertama adalah aman, setelah itu efek samping yang rendah, efektif, durasi yang akurat, menggunakan teknik yang paling sederhana atau sesimpel mungkin tanpa komplikasi lanjutan. Jadi semakin kita menjauhi dari sentral atau semakin perifer blok dilakukan, tentu kondisinya akan semakin lebih ringan komplikasinya dan lebih pendek. Jadi semakin sentral kita lakukan bloknya, kita misalnya semakin ke arah neoraksial, komplikasinya akan semakin berat dan semakin durasinya lama. Jadi jika dibandingkan dengan ilioinguinal dan caudal, tentu ilioinguinal lebih dipilih karena kita bisa tidak memperdulikan dari mana root itu berasal. Dari ilioinguinal itu kita tidak memperdulikan apakah dia berasal dari L1 atau L2 ataupun di torakal 11-12. Tetapi jika di caudal ada kemungkinan blok kita tidak sampai di tingkat torakal atau pada kondisi kita ingin mencapai di tingkat torakal, kita memberikan volume yang lebih tinggi pada pasien. Jadi menurut Dr. Luke, ilioinguinal lebih dipilih pada kasus hernia. Okay, thank you for your attention. Now I will return to the MC2 for leading this event. Thank you. Ya. Ayo.
Okay, thank you so much for Dr. Luke Tillens and Dr. Putu Herita Sudiantara and Dr. Kade Putu Aguseriana for the excellent presentation. And today, before we move to the next session, we will take a picture together. Okay, maybe everybody can. Foto dulu, after picture dan
Yeah. So we stand there.
Yeah.
Okay. Sit down again.
Yang belakangnya bisa berdiri berdiri biar kelihatan semua ya. Yang di depannya duduk aja nggak apa-apa.
Foto. Halo. Nice. So good. Sit down. Thank you. Terima kasih. Yeah. We will show the demonstration. Okay.
Where did you stay here?
Huh?
Where did you stay here?
No, we came this morning and we will go to the have holiday in Padang Bay.
Oh yeah.
Yeah.
So,
No. From here. From here. to
Okay,
the beach
before
side.
we move to the next session, we will have 10 minutes, 5 minutes break. Okay,
Yeah.
is it,
to prepare.
to Holland?
24th.
24th. You
Yeah.
stay on holiday here?
Yeah, stay holiday, and then we go Wednesday to Jakarta, and then I stay with my wife in Jakarta till Sunday. Sunday I fly
Your
back.
wife still here also?
Yeah.
that's
So
good.
she's, I think she's somewhere,
Oh yeah.
but I'm not sure.
Yeah.
Yeah.
Istrinya.
Is it good? No, it's maybe she will have a calcification of the ossacrum, and if the ossacrum is more and more calcified, cannot really look into it, and the calcification will also be into the channel of the sacrum, so that the spread of your local anesthetic will not be eagerly anymore, and you might have patchy blocks. So after 8 years of age, we actually don't do really caudal blocks anymore. Right? We don't have a patient below 8 years old, but this is more an adult, but we're still trying to find the right anatomy to see. I've never done it, but we try it. Right? Okay, let's see. I first put my probe, let me put this here, transversely to see these corneas, to find them. No, it's not freeze. It's late. It has a late reaction. Can you see what I see? Frog eyes? One cornea, two corneas. In between this grayness is sacrococcygeal membrane, and this is the anterior complex. It's the anterior part of the ossacrum. So this here is the caudal space in this patient, and this is transversely. Now we are going to turn the probe 90 degrees. We're going to try to find a bit deeper. It goes deeper, it goes deeper, goes deeper. Goes deeper. Let me test here. It's frozen now? No, it's not frozen, right? There we go. Can we put this on freeze? What you see now is, you see there is nothing here. That is because this is bone. This is bone, the posterior part of the sacrum, while in a kid this is more cartilage. So you can see here the anterior part of the ossacrum, these white lines. But that's the anterior part. I can't see it because this is already calcified. But you see here the double layer, which is the sacrococcygeal membrane. Upper layer, inner layer. And this is ventral part. So this blackness here is his caudal epidural space. And you see, you have to go with your needle through this line. You come from here, in plane, you push it forward, and it comes into here. This blackness is epidural space. From here down, this blackness is shadow from the bone. But this is a slightly grayness, which is epidural space. And the continuation of the epidural space is here, but you can't see it because it's all calcified. But you see, I never saw this patient before. You put the probe, you see the frog sign. You put the sagittal layer, you will find this. Look at my video. Find it on internet, Caudal, ultrasound guided. You will see all the time the same pattern. And if you have that pattern, your needle should come in plane from this side, going through this layer, whoop, into this grayness. That's your epidural space. So we can't find it. Someone wants to try?
Ada. Oh yeah.
Put a transverse where you expect more or less to be the frog sign. Then what you already see there, there's one hump. Try to see the other hump a bit more on the left side. I think there it comes, there it comes. One cornea, two corneas. One cornea, two corneas. You got it already. In between here, if you have slightly titched, this is the art of scanning. The art of scanning is from Vincent Chan in Toronto. He said, yeah, you need to learn yourself the art of scanning. It's an art. But what does the art stand for? Alignment, rotation, tilting. What is the art? The art is your slightly movements of your hand. If you do it this way, it's tilting. If you do it this way, it's rotating. If you do it this way or that way, it's alignment. Alignment, rotation, tilting. Art of scanning. How funny, Vincent Chan. But he's learning himself, and now he is already having his image. Put your needle in. Did they pay you to put the needle in? No. Sorry. Oh, no needles. How was that? Difficult? Someone? Try. Just try it. So you start transfers to see the frog sign. Have a look here. Your image is there. You look just there. You have, what do you see? There's already one cornea there, right? You see maybe the other one is there, so you maybe should move. There it comes. What do you have already? Try to make it as nice as you want it. Make sure that you see here the anterior complex. You go a little bit lower or a little bit higher, it will be there. There you come. There you are. You see it? Now you turn the probe 90 degrees in the axe of the probe. Turn it 90 degrees. Go on. Ooh, what's coming there? Ooh. Try to move it a little bit like this side. Here. Ooh. How are you looking there? Try to find this image a bit lower in the body, a bit like there. Sometime now try to find up and down to the bed. Go a bit down to the bed. Try to find that image. Yeah. Go down. Do you realize he turned the probe 90 degrees the other way around? So now caudal is on the other side and cephalic was on this side, while we turned it cephalic here and caudal there. You realize, you see that? Try to move it a little bit like this and try to find it here. There you get your image maybe better. Small. Ooh. There you are. You see it? It's the same kind of direction. Bone shadowing. So you need to find this anterior part. And then if you see the anterior part, there is some blackness here, which is epidural. And these two lines together are making your sacrococcygeal membrane. It's all about pattern recognition. See the frog eyes? Know that you're there. Try to turn your probe from stand up sagittally. Find this mouse tail or whatever you call it. And be sure to have this part in your image. The anterior part. Because it's the anterior part that's guiding you. As with the frog eyes, you might see the frog eyes, but if you don't see the anterior part, you're not knowing how wide the epidural space is there. Yeah? Yeah, we clean it here a little bit, make it dry. Okay, now you go down on your back. Now we're going to see the abdominal wall. Yeah, it's like this. You keep it's enough. Just the abdominal wall. You put this a little bit down here. Like that, it's enough. Okay. There is gel here. Here, it's enough. No, you don't need that much gel. If you start, you should make sure you have enough gel. No, it's okay. Just to explain you a little bit how to use ultrasound, Actually, everything we do in a daily practice, in our daily work, in our daily being, is routinely. There's also a routine in using ultrasound. The routine is actually there by always trying to do the same things. And in the routine, it starts, how are you going to situate yourself? Am I going to do the ilioinguinal block having this the scanner here and then looking like this, or do I have it like this and work like that? It's easier to work over your hands looking at the screen instead of standing like here and then look there. Right? It's easier to make an alignment with your needle under the probe straight in front of you instead of having the probe here and I'm doing my needle like this. Well, you understand what I mean? Make sure that's all in one line. My hands, my probe, my needle towards the screen. So I see in one direction everything. And you have to change your situation until you got that. If you want to do an interscalene block in this patient, I can put my probe here and I put my needle like this. Having my screen here, I'm looking over my hands to the screen. But I have to look here to make sure my needle insertion is right under the probe. So why don't I put my screen here, have my probe like that, and I'm working in the same line. I'm doing femoral block, putting the screen here. Why not the screen there? Put it like that. If I would do an ilioinguinal block in this patient on the left side, and I'm going to do it from medial to lateral, I should stand there and have the screen here, because then I do it like this. So I'm actually prepared to do a perfect ilioinguinal block on the right side of this patient, because I have the probe like that and do it like that. But then you might not exactly see what I'm doing, so I prepared a bit like this, but this would not be exactly the situation when I was doing the block. Sometimes I do the block in two sides. I do first one side and then turn everything around and then do the other side. I did that with students in Tanzania just to show them the easiness of standing on one side and push exactly away from you. But with a little bit of experience, I'm sitting here, do one block, do two block, clear. One block towards me, one block away from me, but that's with a bit more experience. If you start, try to sit always like this. That's the situation. Then you have your machine. Put it high frequency. The more frequency, the sharper your image will be. The sharper your image will be, the better you can see the structures you want to see. So if you put the energy low, frequency low, there will be less nice image. Put it as high as possible. We are not going to look deep. If you want to look deep in the patient, you need low frequency. But most of our structures that we want to reach, the nerves, are not more deeper than 4 centimeters. So you can use high frequency. 4 knobs. 1 knob, put it on. 2 knob, put the frequency as high as possible. 3 knob, adapt the depth to the depth that you might expect your structure to see. If I want to look ilioinguinal or caudal, you saw already, I know already, it's about 3 or 4 centimeters that I need to look. Ilioinguinal for this patient, 3 max. So I can lower already the depth. Is this the depth? No, this is depth. 3 centimeters. Lowering my depth means I will concentrate the whole image in a lower part, making your image better. Putting some gain. If I'm going to look for white structures, I might put the gain a bit black, because then the whiteness will appear better. If I'm looking for black structures, vessels, I put the gain a bit whiter, so this blackness appears more in the whiteness. And I know where my vessels are. And if I got my vessels, I can change a little bit the gain to see the nerves, which are whiter. So I need maybe a bit more blackness. You understand? All things that you do before you even put the probe on the patient. And then you decide, okay, now all is done in the routinely, your situation and 4 knobs. You start to put the probe on the patient. And the probe needs a lot of gel to make a good contact. Otherwise you don't have a good image. So good gel. Yes, and I'm a bit more experienced, so I can use less gel, although it's walking already. Right, gel. And then the probe goes on the patient. Orientation. What is actually left and what is actually right in my image? In literature, they decided about 10 years ago, let's make always left lateral in all the pictures we make. That means that the pattern is always the same. And if the pattern is always the same, the only thing you have to do is find the pattern. If you turn the probe around, the pattern is the same, but it's mirrored. Left is right and right is left. So in literature, it's very important to make always the same picture, always the same image, always the same pattern. But in my patient, I'm going to put a needle in. I want to know what is right and what is left in my image and in my patient. If I put the probe on the patient and left side of my screen is right side in the patient, for sure I have my needle in and I'm looking at the screen. Oh, I need to go in the screen a bit to the right. Oh no, that was in the patient to the left. Twice your needle going in and out. So make sure that the orientation of your probe is in your mind okay. And in my mind, I like to have left of the screen is left in my patient or left for my probe. And right side of my patient is right side in my screen. Yeah? Now I'm telling you, sit like this and have it in line. That means there is no left or right. There is something close to me and something away from me. And then, if you have trained yourself a bit doing this, then you realize, okay, I want to have close to me always on the left side. Because then I see my needle always from that side coming in. And I get used to that. I can change it, change the probe around, and then my needle comes from the other side. But it still goes away from me, but it's different in my image. That's the only thing. You can train yourself in trying it once this side, trying it once the other side. What do you like the most? That's what you're going to use. And if you use it like close to me is always left, then finally every patient you're going to sit down at and do your block, close to you will come from the left side. In this side, that means it's lateral left. That's nice because literature told me I should do that. But if I go to the next side, it's different. You understand what I mean? But orientation has nothing to do what literature wants. Orientation has to do with you are going to stick the needle in. So you need to know what your orientation is in that patient. Right? Okay, I have made my orientation. I want to have close to me from the left side. That's like this, holding it like this. There is a notch or a ridge or whatever there that can show you what is my left side. Where did I leave that one? Oh, here. What is this marker here? That's compared to this ridge and that bulge there. So I know that this side is my lateral side. Right? So left in the screen will be lateral. Then you put the probe on the patient and you start to find your anatomy. Our radiologist told us, always when you use ultrasound, the moment you put the probe on, there should be one structure, you definitely know what it is. Because from that anatomical structure, you will go to find your way around the rest of the anatomy. If you do interscalene block, what will be the first structure you definitely know what it is? Carotid artery. Supraclavicular, the artery. Axillary, axillary artery. Femoral, femoral artery. Popliteal, popliteal artery. Abdominal wall, muscles. Which muscles? external oblique, internal oblique, transverse muscles. There should be 3 muscle layers. What about ilioinguinal? There is the bone. Sphenoiliac anterior spine. The bone is guiding me from the bone towards the 3 muscles. So, now I'm prepared. Let's see what we see in this patient. We trained yesterday about 2.5 hours to show you directly what we need to see, but that was a secret. I'm a good anesthesiologist. Oh, still he's awake. He's awake. There we go. We put the probe on the patient. We put him on the iliac spine, and now you see the bone on the left side of your screen, right? This is the bone, and this is shadowing of the bone. So I have to look here for some muscles. What do I see? One big white line, and that might be, because I'm below the umbilic, the external oblique muscle, which is only upper nerosa. And then from that white line there is a muscle layer, but is this muscle layer till here or till there? Is this intern and this transverse? Or is this intern and this transverse? You see a lot of white lines here, and if a muscle is connecting to the bone, it becomes all little tendons that are going to be woven into the periost of the bone. It's not that they have a way of connecting, like, okay, now it's stuck, but these muscle fibers become tendon fibers, and the tendon fibers go into the periost, and then the muscle is connected to the bone. Meaning, close to the bone, there will be always white tendon lines going towards the bone. So that makes it a bit of a hassle to find out which of these lines is the fascias between the 2 muscle layers. To make sure of that, I'm going upwards towards the nose, and what happens with the upper layer? The upper layer opens, go back to the bone. Oh, now it's a white line, and there's the bone. Go from the bone towards the nose, this layer opens, and that opening, this is external oblique muscle, internal oblique muscle, transverse muscle. Meaning this is the line between intern and transverse. And here you see a bit movement is the peritoneum. So if I start only here, and I might have a problem to see which line is what. Is it this line, or is it maybe there, or is it maybe this one here? It is a bit not really clear. But this new anatomy learned us, if I go a little bit higher up with my probe, you cannot see my movement of the probe. Is it videoed somewhere? But I'm moving upwards, and then you see this muscle is going to open, and this line is getting whiter and whiter. And you see the vessels in there. And maybe this is the nerve, also with a small vessel. But I need to be in this line. It's still not a really bright line, so I go a little bit more up. This muscle is opening, and it's getting a bigger and bigger line. My needle has to go in from medial, because this was lateral, the bone, from medial to this line. There's intraperitoneal, transverse muscle, internal oblique muscle, external oblique muscle just opening, and this is the line where I want to end up with my needle. Someone to try? So you did all the preparation. Put your probe on top of the spine, and then in the direction of the umbilic. So you keep it a bit in this way. There you are. Now you see. Go a bit really on the spine to make sure. Okay. There I see bone. I definitely see bone here. You see what he did? He turned around the probe. He is now having close to him, away from him in the screen. Well, it's right. It's not away, it's the right side. But he knows now that his needle will come from this side, going in from this side. But you see, Now turn your probe 180 degrees and put it on again. Put it like this. Like, hold it, yeah. Whoop, now hold it again. Put it on the bone. There you are. Hey, now it's 180 degrees flipped. So this you can decide by yourself. What do I want to see? How do I want to see it? From which side do I want to see my needle coming into my image? This is definitely the bone. From the bone, there is some kind of lines going to the other side. A big white line, some muscles. It looks like it is this line already. Now you move slowly towards his nose. In this position, just move towards his nose. And then you see what's opening up for you. It's there. Try to open that more and more. Go up, up, up. This muscle will go open. It's already open here. Go up a bit, sorry. It's frozen. There we go. Now you have an open one. You see the white line? Now the muscle is open and it's this line. Now the muscle is too much open. This white line is too much. So go a bit lower, where it's almost opening. Bit lower, more to the bone, back to the bone. Yeah. There you have a nice white line. There you have one. You see it? You see it here? This one. So your needle has to come in from here, going in till you are in this line. You will have to go outside the muscle and in between the two muscles. If you push, and you don't know if you're in the line, you might still be in the muscle. How do you know? Leave the tension a little bit. Push your needle upwards. Push the needle like that towards your probe. If you push your needle like that towards the probe, it let loose of the line and there is still muscle between the line and your needle point. You know that your needle point is not in the line. The moment you are out of the muscle and in the line, in that virtual space, and you're going to push up your needle, you're doing like this, you will see the line going directly up, you're in the line. You also can do push it through and through. If you are in the deeper layer, you're definitely in the deeper layer, you see your muscle, your needle there, you went through the fascias. Then you withdraw it, but don't withdraw it the same way because then nothing happens. But push it upwards, scoop a little bit with your needle, and if you scoop it with your needle, you withdraw it, and then your muscle falls down from your needle. And then you know the deeper muscle falls down. I am in between the two muscles. You do your injection, 0.5 ml, blackness. 2 ml, sea of blackness. And you are done. Yeah? One more trick. I told you in the abdominal area there is like rectus sheath block, there is tab block, and you want to know which muscle is where. Right? You saw here muscles easily to find. What do you think if this six-pack is more like a barrel as mine or even bigger? Will be those muscles more bigger? Will these muscles be found easier or more difficult? The bigger the belly, it's not more easy. But the bigger the belly, these three muscle layers are always on top of each other. There is no fatty tissue between the muscles, there is fatty tissue on top of the muscles or even below. Intra-abdominal fat and abdominal fat. But the muscle layers are always connected to each other. If you just put the probe on top of the abdomen and you try to find muscles, if you do that in the midline, you might see on both sides a muscle, it's called rectus abdominis muscle. Right? The rectus abdominis muscle has the linea alba in the middle. What if the belly is like this big? The linea alba is less or is bigger? It's wider. You might put the probe in the middle of the abdomen and you don't see any muscles at all. It's just linea alba. You need to move laterally one side or the other. But is this muscle easy to find if it's just one muscle? It's much easier to find the three muscle layers. Where can I find them? Lateral from his six-pack or my barrel. Lateral you will see the three muscle layers. And these three muscle layers are on top of each other. Let's have a look. Did we have some more gel there? One was open. There's enough gel. Okay, let us put it here. Easy going in this patient. Huh? Three muscle layers. Which one is what? Transverse muscle has transverse fibers. They go exactly in the same direction as the probe. Internal oblique muscle and external oblique muscle have the fibers this way and that way, meaning they are 90 degrees towards each other. And transverse is like this. And these are like that on top. What happens if I move over the muscle layers towards the nose and back to the toes? Transverse muscle fibers are not really seen. So the transverse abdominis muscle will be kind of a blackness. There might be moving something, but not that much. But the internal oblique muscles going that direction is if I move this way, they go that direction. But the external oblique muscle has the fibers like that. So if I move this way, it goes that way. So what is this doing? If I go to the nose, it's doing this. And what if I go back to the toes? It's doing that. And then I can identify external oblique muscle, internal oblique muscle, and transverse abdominis muscle. And then I know my three muscle layers are there. So if I put the probe like that on the patient, I see three muscle layers. Three muscle layers, I move to the nose, and I move back. You see what happened in the two top layers? Up, down, up, down. Underneath is just blackness, and these muscle layers are doing this, that, this, that. Did you see it? So I can identify my three muscle layers. There's no bone. There's no vascular axis, vascular structure like an artery or something like that. But I have identified the three layers in this patient. Right? And from these three layers in the patient, I can go medially, and what's there? They three muscles. Where did I put it here? These three muscles are ending 1, 2, 3, and something new happens to be here. What is this muscle? What is that muscle? That is rectus abdominis muscle. And then goes over the midline. Doesn't move there. Go over the midline, and we see it on the other side. Rectus abdominis muscle going to the lateral border. Kiekawoo, three muscle layers. It's a bit less gel. 1, 2, 3. Same structures. The other side of the abdomen. It's mirrored. It's all the same. Right? If you have a look for here, seeing the rectus abdominis muscle coming, you know that the nerves, the nerves are on top of the transverse abdominis muscle going into the rectus abdominis muscle. And then you maybe have heard of a rectus sheath block, which you can do underneath the rectus abdominis muscle into the sheath. Let me try to find nice image. There you are. This is the lateral border of the rectus abdominis muscle. There. And this is a little bit more medial. Then you see a nice double layer, which is the posterior aspect of the rectus sheath, and this is all rectus abdominis muscle. The nerves are walking here underneath the muscle, perforating through the muscle to the skin, going to the midline and back to the lateral border of the rectus abdominis muscle itself. And you can put some local anesthetic here on top of this double fascia, blocking at that level, and maybe a level higher and a level higher, the intercostal nerves that go to the medial part of the abdominal wall. And that's called rectus sheath block. Look it up on the internet, rectus sheath block. Where do you do it? You need to find this pattern, but coming from the lateral wall, 3 muscles, going to the side and a bit further. You put your needle in at this level, on top, in the rectus sheath, not intra-abdominally, in the rectus sheath, but under the muscle. Yeah? Okay. Yep, we still time? Still time? It's okay? Yeah. Just put your probe transversely onto the abdominal wall and try to find your way to know what is my anatomical structures in this patient. You see now, this is a six-pack, it's one muscle. So go laterally, go lateral, 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 more. There you see like 3 muscle layers. You see it? 1, 2, 3. Now try to go a little bit more lateral, and you see really 3 layers. And now you move this probe to his nose and back. Now you see what's happening there? You see this one is going that side. You look and you scream there. Yeah. Move it downwards. Downwards to the feet. It's a little bit hesitating here. Can you move it again? This is a bit like has a delay. It makes, if you look at here, it looks very good, but if you look at there, it's a bit different. Try to show it here. Oh, it's frozen now. Yeah. You have a quick look here. Do you see the movement? Can you see it there? Not that good, because a bit delay. But, okay. Difficult to find? Don't say yes. With a little training, you can find these structures. You can find a place to do ilioinguinal block. You can find a place to do caudal block. Remember, do a block. Not having ultrasound, still do a block. Having ultrasound, try to use it. Don't be as my colleagues, having ultrasound and not using it. Right? Use your ultrasound, do your blocks. Okay? Thank you very much. Clean him, clean.
Thank you so much, Dr. Lutilens, for the enlightening live discussion. Okay, your insights have provided us with a understanding of pediatric anesthesia. And thank you everybody who has joined us today. So see you on the next guest lecture. Thank you.
Thank you. Terima kasih.
We're done. Thank you very much. Thank you.
Hope it was okay.